If you have PMR and you've tried to taper your prednisone only to have your symptoms come roaring back, you're not alone. You go back up on that dose and wait a while, try again, and then the same thing happens. After the second or third time of having to go back, you start to wonder if you're ever going to get off of this medication. What if I told you that what may look like a PMR flare during your prednisone taper isn't always just the PMR coming back? For many people with polymyalgia rheumatica, it's also your body sounding an alarm about something entirely different, something nobody warned you about when you started taking prednisone. Here's what I want you to picture. Your adrenal glands are like a factory that makes cortisol, your body's own natural steroid. When you take prednisone, that factory essentially shuts down. And then when you try to taper, when you try to restart the factory, most doctors are focused on the shutdown. What nobody talks about is whether the factory has what it needs to get started again. I'm Dr. Megan. I'm a board-certified doctor of pharmacy and third-generation pharmacist. And I'm someone who has personally taken prednisone and been on a taper roller coaster. PMR is the condition I see in more prednisone warriors than any other. And today I want to explain both parts of this problem because understanding them together changes everything about how you approach your taper. So check out this roadmap of where we're going by the end of the video. I'm a visual person and I like to see what it might look like. So your adrenal glands. They're these two small glands that sit right on top of your kidneys. They're your body's natural cortisol factory. Every day on a reliable schedule, that factory produces cortisol, the hormone that regulates your energy, your immune system, your stress, your blood pressure, your blood sugar. You cannot live without cortisol. The factory must run constantly unless you take prednisone. When you take prednisone, which is a synthetic or fake man-made version of cortisol, your brain receives a signal. Cortisol is being provided. It's coming in from the outside. You don't need to do that job anymore. The factory doesn't need to run. We're importing this one. So it slows down. It shuts the production line. The workers got laid off. They go home. This is called adrenal suppression, and it happens to virtually everyone who takes prednisone long enough. It's not a dramatic side effect. It's just your body's logical response to an outside supply. The problem is when you try to turn the factory back on, because now you are saying, we're going to turn down the imports and start trying to make it ourselves. So why PMR patients' factories have been closed the longest and why this is the most important for people with PMR. The average PMR patient is on prednisone for at least 12 to 24 months. On average, it's even longer than that. And for many of you, it's even longer. About 20% of people are still on prednisone 5 years after PMR diagnosis. That means that your factory has been shut down longer than almost any other patient group. The longer the closure, the harder the restart. The workers found new jobs. The machinery is rusting. The equipment hasn't been run or oiled. And the factory needs time and resources to come back online at every step of the taper. Add to that the typical PMR patient's profile is predominantly female and over 60, means that you're often managing other conditions in addition to PMR. All of these factors slow the restart. So when your dose drops during a taper and your adrenal glands haven't restarted quite enough yet to keep up, your cortisol level falls, and the symptoms that follow, fatigue, achiness, stiffness, just feeling awful, can look almost identical to a PMR flare. It can be really hard to tell the difference. Your doctor might see these symptoms, call it a flare, and say, let's raise the dose again. That means your factory closes yet again, and the cycle continues. Sometimes it really is a PMR flare. But sometimes it's just a factory struggling to reset and restart. And those two situations do need different responses. The clue is in your labs. A true PMR flare typically shows up in blood tests like ESR and CRP, your inflammatory markers. A struggling factory usually doesn't have inflammatory marker flares. So if your labs look normal, but you feel terrible while tapering, this is a conversation worth having with your rheumatologist before automatically going back up. So before I get into part 2, the part about what the factory needs to be able to reset and restart, I want to make sure you have a tool in your hands. I created a free prednisone taper chart based on the latest Endocrine Society guidelines, specifically the slow taper approach that gives your adrenal glands the best chance to come back online at each step. The prednisone taper chart is free, it's printable, and it's something that you can bring to your rheumatology appointment and actually use in your conversation with your doctor. Click the first link in the description below or scan the QR code on the screen to download it now. Go grab it and then come back, because part 2 is where most patients have never been taken before. So here's what makes the PMR taper problem even more difficult, and why most doctors don't have the full picture. Prednisone doesn't just shut the factory down. While it's been running, prednisone has also been depleting the factory's resources, the raw materials, the equipment, the things the factory needs to properly restart and continue running properly when the time comes. This is a documented pharmacological mechanism. It's not controversial. It's not alternative medicine. It's in the clinical literature. Prednisone changes how your body absorbs, uses, and excretes certain nutrients. And some of the nutrients being depleted are specifically the ones your adrenal glands need and depend on to produce cortisol again. So you've been asking the factory to restart, while the medication that shut it down has also been draining the resources that it needs to run. Kind of like embezzling from your boss while he's put your factory on hold. That's the real reason why tapering is so hard for PMR patients. And it's the part almost no one explains. Every factory needs something to fire up production. For your adrenal glands, vitamin C plays that role. This is published in the American Journal of Clinical Nutrition. When researchers measured what happens inside the human adrenal gland during cortisol production, they found that vitamin C is released from the adrenal gland right before cortisol. It actually precedes the cortisol surge. Adrenal glands are unusually rich in vitamin C if they're healthy. And vitamin C acts as a cofactor for the enzymes involved in cortisol synthesis. Vitamin C isn't just nearby, it's part of the process. Prednisone depletes vitamin C. So the medication that is shutting down your factory is also taking away the spark your factory needs to fire back up. That's a compounding problem. Next, a factory without workers can't produce anything. No matter how good the equipment is, for your adrenal glands, B vitamins are the workers on the production line. Cortisol synthesis requires a compound called acetyl coenzyme A. B vitamins are precursors to acetyl-CoA. They're what the body uses to build the molecule that the entire steroidogenesis pathway runs on. Research shows that B vitamins are directly involved in the production process, and that supplementation enhances the adrenal gland's ability to respond to the signal to produce cortisol. But prednisone depletes B vitamins over time. B1, B2, B3, B6. Send the workers home long enough, and the factory doesn't just slow down. It loses the institutional knowledge of how to run at full capacity. That makes the restart slower and harder. But even with the spark and workers, you need functioning equipment. Magnesium is the machinery that keeps the whole operation running smoothly. Magnesium plays a documented role in regulating the hypothalamic pituitary adrenal axis, the management system that tells your adrenal factory when and how much to produce. Research shows that magnesium deficiency is associated with dysregulated cortisol patterns, a factory that misfires, overproduces at the wrong times, or can't respond appropriately to demand. Prednisone increases magnesium excretion through the kidneys. You're peeing it out because of prednisone. The machinery is being worn down while the factory sits idle. And many of the symptoms that PMR patients describe, muscle cramps, poor sleep, fatigue, mood changes, are also symptoms of magnesium depletion. Two things happening at the same time with overlapping symptoms. Finally, even if you have the spark, the workers, and the machinery, the factory has to be in a condition to operate. Vitamin D determines whether the factory itself is fit for production. Vitamin D is technically a steroidal hormone. It speaks the same biochemical language as cortisol. They're structurally related. They're cousins chemically. Research shows that adrenal tissue expresses vitamin D receptors, meaning that the adrenal gland is directly responsive to vitamin D status. Studies find that vitamin D deficiency correlates with abnormal cortisol rhythms and may impair what researchers call adrenal resilience, the factory's ability to respond when called upon. Yet, prednisone impairs vitamin D absorption in the gut and increases excretion. A factory with depleted vitamin D isn't broken, but it's operating in a compromised facility. The restart is harder. The output is less reliable. So here's the full picture of why tapering prednisone is so hard for PMR patients. Prednisone shuts the factory down. While the factory is closed, it depletes the spark, sends home the workers, wears down the machinery, and lets the facility deteriorate. Then you try to taper off, and you're asking the factory to restart with less of everything that it needs. And your doctor, who's focused on the shutdown, may not know to look at those resources. This is not your fault. And now you know what most patients and most doctors have no idea about. So what can you do about it? First, the 2024 Endocrine Society created guidelines about tapering prednisone. And they recommend tapering prednisone by no more than 1 milligram per month once you're below 5 to 10 milligrams. And then holding it at each level long enough to see if the factory can actually start kicking in. Signs that the factory is struggling rather than your PMR flaring: extreme fatigue, dizziness, especially when you stand up, nausea, feeling flu-like, even when your labs look normal. Flag this with your doctor or your rheumatologist before going back up on your dose. And my taper chart in the description below goes through all of the options of how you can taper step by step. So the second action you can take is to resupply the factory. Ask your doctor to check your vitamin D status. That's in the guidelines too, especially if you've been on prednisone for more than a few months. If your doctor doesn't have a vitamin D test, I have one in the description below. You can order it yourself. Think proactively about what you're doing to replenish what prednisone is taking. The spark, the workers, the machinery, the factory itself, all of them need attention, not just the tapering schedule. You now understand something that most PMR patients and doctors never find out about: the factory shutdown and the resource depletion that makes the restart so hard. That's the two-part mistake, and now you know both parts. But here's what I haven't covered yet. Prednisone is doing several things to your body at the same time, things that go beyond just the adrenal glands. Prednisone is affecting your bones, your blood sugar, your sleep. Most patients find out about these things only when things have already gone terribly wrong. So there's a reason I made an entire video on this topic. It's the most important one I've ever made on this channel for someone on long-term prednisone. It's called The Number One Mistake You're Making with Prednisone. You got one taste of how we can solve this problem in this video, and my next video will help solve the rest of the problem for you. If you feel like your doctor just doesn't understand what you're going through when it comes to PMR, this video is for you. A group of researchers just did a thing your doctor hasn't done. They spent a year reading over 1,000 social media posts about PMR, which is polymyalgia rheumatica, and GCA, which is giant cell arteritis. These weren't surveys, they weren't interviews in a formal sitting, not clinical interviews in a formal setting. These are the real, unfiltered things that patients say to each other in forums and in public posts on social media when there's no doctor in the room. And what they found was published in a peer-reviewed journal, which means science has now officially documented what you've been living. Your experience isn't anecdotal now, it's in the research. I'm Dr. Megan. I'm a board-certified clinical pharmacist and third-generation pharmacist. And I've personally had to take prednisone from my own autoimmune disease. I read this study carefully so I could break it down for you, because I think every PMR patient and prednisone patient deserves to know what the researchers found when they actually studied what you have to say. This study was published at the end of 2025 in the journal Rheumatology Advances in Practice. Researchers analyzed over 1,000 social media posts from PMR and GCA patients in the United States and Germany, written between 2022 and 2023 in forums like Reddit, X, Facebook, and other public forums. They weren't looking what doctors said about PMR. They were looking at what patients said to each other and in public. And the picture that emerged is one I think you'll recognize immediately. The most common thing patients talked about, by far, was treatment. 33% of all posts were about medications. And when researchers looked at the emotional tone of these posts, 61% of them expressed a negative sentiment about their medications. The number one source of that negativity? Glucocorticoids like prednisone. One said, prednisone fixed the pain, but now I'm dealing with all of this, all the side effects. Patients weren't saying that prednisone doesn't work. Most acknowledged that it helped, and sometimes dramatically within 24 to 48 hours. The miracle was real, but so was the misery that followed. Side effects, intolerability, flares every time they tried to taper, and a cumulative sense of feeling trapped. When patients described what prednisone was doing to their quality of life, the picture was layered. Patient posts reported side effects such as insomnia, high blood sugar, and rapid weight gain from long-term prednisone use. And then describing the disease as pain, difficulty walking, fatigue so heavy that they couldn't plan their days around it. But researchers also documented something that often goes unspoken in a clinical appointment: the emotional toll. Feeling anxious, confused, helpless, frustrated. One of the things that the study highlighted was the unpredictable nature of PMR. Never knowing when a flare might come, never knowing how the taper will go. And that was a direct source of anxiety for patients. Not just discomfort, anxiety. And that distinction matters. I felt the same way with my autoimmune disease. Like, was it going to flare if I tapered? Or was I finally going to be able to get off prednisone? Every time I tapered, it was scary to find out what was going to happen. Before I share the third finding from this study, I want to make sure you know about a video I made that I think is the most important video for people with PMR. It's called The Number One Mistake You're Making with Prednisone. Everything that this study we've been talking about documents, the side effects, the frustration, feeling like something is being missed, my new video addresses the root of that. The link is in the description. Please watch it after this one. Now back to what researchers found. Here's something that surprised even the researchers. Despite biologic medications or biologics being used by only a minority of PMR patients at the time of this study, patients who mentioned biologics spoke about them much more positively than they spoke about prednisone. More efficacy mentions, more remission mentions, fewer side effect complaints. This matters because it tells us something about where prednisone patients' hopes are right now. They know that prednisone works. They're just desperate for something that works without costing them so much in side effects and other consequences. Here's the part of the study that I found most striking, and the most important part for you to understand. Researchers found that 60% of patient interactions with healthcare providers were described negatively. Long wait times, delayed diagnoses, misdiagnoses, feeling dismissed, feeling like their doctor didn't understand the full weight of what they were carrying. Now, I'm grateful for doctors. I'm so glad they exist. It's not their fault, their long wait times, right? I don't think most rheumatologists are bad doctors. I really don't. But there is a structural problem. A typical appointment gives your doctor 7 minutes with you to check your labs, adjust your dose, make sure your diagnosis is actually correct, and then move on to the next patient. 7 minutes was never designed to be long enough to be enough for a PMR patient and what you're dealing with. The study found that the most common unmet need patients described wasn't a new drug. It was this. The patients felt their doctors lacked awareness of what their experience actually involved and didn't provide enough information about their condition, its causes, or their options. Patients weren't asking for miracles. They were asking to be informed, to be heard, to have someone explain what was happening in their bodies in language they could understand. One PMR patient said, "My rheumatologist's standard response to my question is, 'That's outside my scope. If it isn't him, then who the heck is it?'" That quote broke my heart a little when I read it, because that person isn't wrong to be frustrated. They were diagnosed with a serious inflammatory condition, put on a powerful medication with significant long-term consequences, and then told that their questions don't belong anywhere. That's the gap this channel exists to fill. The study found that patients weren't using social media to replace their doctors. They were using it to fill in the gap between what appointments couldn't cover, to find people who understood, to hear others' experiences before starting a new medication, and to process fear in community with people who understand. 70% of patients in one rheumatic study had sought medical information through social media, not because they distrust medicine, but because they need more than 7 minutes can give them. And here's something else the researchers noted. The patients who felt most informed and connected online actually communicated better with their doctors. This isn't doctor versus the internet. At best, it's both working together. So if you have felt dismissed, if you felt like your side effects are being minimized, if you have felt anxious about tapering and had no one explain why it's so hard, if you spent time on Reddit or Facebook at 2 a.m. trying to find people who understand what you're going through, you're not overreacting, you're not weak, and you're not an outlier. You are the data. A peer-reviewed journal just documented what you are living. And that matters because the medical community can no longer call this anecdotal. It's proof. It's scientific evidence. Now let's talk about the flip side of this. The same study that validated the way you're feeling about your disease found something worth paying attention to. Social media platforms and their algorithms are designed to amplify posts that generate strong reactions, which means that the most dramatic stories, the worst side effects, the most frightening outcomes, the most dire tapering experiences, they tend to get the most visibility. And that's not representative of everyone's experience. And spending hours absorbing the worst case scenarios at 2 a.m. can amplify your fear in ways that aren't helpful and feed that prednisone brain that just spins and doesn't let you sleep. So here's how I'd encourage you to use social media as a prednisone warrior. Use it for connection and community. Use it to know you're not alone. But come to places like this for clinical education, because I'm going to give you the mechanism behind what's happening, not just the experience of it. Those two things together are more powerful than just one alone. And I personally host a Facebook community for prednisone warriors called Prednisone Support. In it, there are thousands of people taking prednisone who come together and talk about what it feels like. And probably a majority of them have PMR. So this study we've looked at is a tool that you can actually use. If you felt dismissed at appointments, you can now tell your doctor literally that peer-reviewed research has now proven how you feel. If you've struggled to explain how you're going through, the emotional vocabulary in this study, anxious, confused, helpless, frustrated, is clinically documented. Those are the words you can use in your appointment and be completely evidence-based. If you've been told your side effects are just part of it, then you're not alone. That's what a lot of people feel like. If you've wondered whether biologics help you, and people felt a lot better about biologics than prednisone, as I covered in my last video, There are now FDA-approved options worth talking to your rheumatologist about. Here's something that most patients with PMR, and honestly, most doctors and pharmacists, don't know. And it completely changes the conversation you should be having with your doctor. Prednisone is what virtually every PMR patient gets for treatment, but it was never actually approved for PMR. Prednisone is not FDA approved for PMR. I know. Think about that for a second. I'm a third-generation pharmacist, and I had never actually heard of PMR before I became the prednisone pharmacist. Because guess what? PMR is not in the FDA-approved package insert. You know, that little packet of paper on the back of a pill bottle? It's not there. It's not listed as an approved indication for prednisone anywhere. So they don't teach about it in pharmacy school, even though PMR is one of the most common inflammatory conditions for people over the age of 50. Prednisone has been the standard of care for PMR treatment for decades, but it was never actually officially approved for it. Doctors have been prescribing it off-label because it works. I mean, it works so well that some doctors actually think they should diagnose PMR because the pain goes away after using prednisone. It's almost diagnostic. And because very recently, there was nothing else. That just changed. I'm Dr. Megan. I'm a board-certified clinical pharmacist, and I'm someone who's personally had to take prednisone for a long time. I attended a Harvard Medical School seminar in Boston where I sat in a room with some of the leading PMR researchers in the world, including the physician who just led the largest PMR study ever completed. And today I want to share what I learned, the latest research about PMR and what it means for you. So how did we get here? How does a drug become the universal treatment of choice for a condition that it was never approved for? I could cover a whole bunch of regulatory laws and changes over the years at the FDA, but it really comes back to prednisone. PMR is driven by inflammation, particularly a few inflammatory proteins, one of which is called IL-6 or interleukin-6. Prednisone suppresses that inflammation powerfully and fast. Most people with PMR feel dramatically better within 24 to 48 hours after the first dose of prednisone. If you give someone prednisone and their PMR symptoms go away almost overnight, that rapid response confirms the diagnosis. So prednisone works. Nobody disputes that. But it works as a broad suppressor of your immune system, not just the specific inflammatory pathway that PMR is triggering. And because PMR is a long-term condition, 12 to 24 months at minimum, and for many of you, much longer. That broad suppression comes at a real cost. A peer-reviewed study published in 2025 in the journal Rheumatology Advances in Practice analyzed over 1,000 social media posts from real PMR and GCA, which is giant cell arteritis patients, who are writing social media posts to mostly each other and not to doctors. Here's what those researchers found. 61% of treatment comments were negative. The top frustrations, side effects and intolerability, flares during tapering, the feeling that the medication was losing its effectiveness over time, and a desperate desire to taper off faster, but feeling completely trapped with no other options. That study also found that patients viewed biologic medications significantly more positively than glucocorticoids like prednisone. Patients were asking, isn't there something else? Anything else? And for a very long time, the honest answer was, not really. But now it's different. In 2023, the FDA actually approved a drug for PMR. The drug is called sarilumab, and the brand name is Kevzara, specifically for PMR, polymyalgia rheumatica. And I want to emphasize that specifically. This is not another off-label indication. Sarilumab is the first drug in history actually FDA approved for PMR. Sarilumab is an IL-6 receptor inhibitor. Remember that IL-6 protein I mentioned earlier? One of those that is driving PMR inflammation? Well, sarilumab or Kevzara blocks it. This drug targets the root cause of the inflammation more specifically than prednisone can. And it's given as an injection under the skin every 2 weeks. In the SAFFIR trial, the study that led to FDA's approval of Kevzara, 28% of patients on Kevzara and 10% of patients on prednisone at 52 weeks. Now, I want to be real with you about what that really means. 28% is truly statistically significant. It is genuinely better than prednisone. Roughly 1 in 3 Kevzara patients achieved sustained remission. That means they were off of prednisone, off of other treatments, and the PMR didn't flare. So it was 1 in 3 for Kevzara, and then only 10% of prednisone patients. So 1 in 10 prednisone patients achieves sustained remission at 1 year. So that is a meaningful improvement over prednisone, but it is not a cure. 2 out of 3 Kevzara patients still didn't achieve that outcome after a whole year of treatment. And the patients that did benefit ended up taking significantly less prednisone over time, which is the cumulative dose, which matters enormously for your long-term bone health, metabolism, blood sugar, and everything else, those 150 side effects I've covered on other videos on this channel. So this is real progress, but it is not a magic bullet. Before I get to what else is coming in the pipeline, which is really exciting, I want to make sure you know about a video I published recently that I think every PMR patient needs to watch. It's called The #1 Mistake You're Making with Prednisone. It's the most important video I've made for someone in your situation. And it addresses the thing I see PMR patients getting wrong more than anything else. The link is in the description below. Now back to Kevzara. Kevzara is currently approved by the FDA for people who have an inadequate response to prednisone to treat the PMR, meaning prednisone just isn't working well enough to control the disease, or people who can't tolerate the taper off of prednisone, that you keep flaring every time you try to go down in dose. But Kevzara is not yet a first-line treatment for people who are diagnosed with PMR. That's still prednisone's role. But the trade-offs are real too. As a biologic, it carries an increased risk of infection. It requires an injection and monitoring. And probably the biggest problem is that the cost and insurance coverage varies dramatically, though coverage has definitely improved since approval. And regarding the infection thing, prednisone causes that too. So it's not really a way to distinguish prednisone from Kevzara. They're both causing an increased risk of infection. But if you've been stuck on prednisone and every time you try to taper you flare, then this is an option that you can bring to your rheumatologist. Many patients have no idea that they can even ask about that. So when I was at the Harvard Medical School seminar in Boston last year, they talked about the upcoming trials, the new treatments for PMR. I was in a room with the leading researchers of PMR and giant cell arteritis studies around the world. And I had the opportunity to learn from Dr. John Stone, a rheumatologist at Massachusetts General Hospital and Harvard Medical School, and one of the foremost experts on PMR in the country. What he recently published just a few weeks ago was the latest results from the Replenish trial. Replenish is a phase 3 clinical trial, the gold standard of medical research, the last step before FDA approval. And it involved 381 patients with PMR who had relapsing disease. These were not newly diagnosed patients. The results were published at the International Vasculitis Workshop in 2026, a major international conference. It hasn't been fully published in a peer-reviewed paper, just at this conference. In this trial, a newer drug was tested called secukinumab, also known as Cosentyx. Cosentyx is already FDA approved for ankylosing spondylitis, psoriasis, and several other inflammatory conditions that I used to review requests by doctors to get their patients on this medication when I worked for an insurance company and reviewed prior authorization requests. So Instead of targeting IL-6, Cosentyx targets IL-17A, which is a different immune protein involved in inflammation. The results. Patients on Cosentyx had double the rate of sustained remission compared to placebo, roughly 41% versus 20%. And they needed significantly less prednisone over the course of the year. Here's what Dr. Stone said that really made me think. He said that patients at high risk of doing poorly with prolonged prednisone because they're older, female, or have comorbidities like diabetes or osteoporosis may benefit substantially from Cosentyx, potentially even as the primary treatment approach instead of starting with prednisone. That's significant. That's a leading Harvard researcher saying we may be able to protect the most vulnerable PMR patients from prednisone's worst long-term effects, starting earlier in treatment. The fact that blocking IL-17A also works in PMR tells us something important about the disease itself. PMR inflammation is more complex than one single inflammation pathway. That opens the door to more targeted specific treatments, more personalized treatments, matching the specific inflammatory driver to the right drug for each patient. It's exciting that that's the kind of precision where rheumatology is headed. Now we know a lot about what works and doesn't work about PMR to help us narrow down what is causing PMR inflammation. They've tested a lot of really popular drugs that work for other rheumatological diseases like rheumatoid arthritis. Drugs like Enbrel and Humira, they did not help people with PMR. But another drug called tocilizumab, which is the brand name Actemra, is another IL-6 inhibitor that has been studied in PMR. In the Semaphore trial, 67% of patients on tocilizumab reached the primary endpoint compared to 31% on prednisone alone. A separate trial called the SPARE trial looked at newly diagnosed PMR patients and found that Actemra helped them get off prednisone faster with fewer flares. It's already FDA approved for giant cell arteritis, or GCA, which is closely related to PMR. So your rheumatologist may already know that drug very well. Some other drugs researchers are studying include rituximab, which is a B-cell depleting therapy. I personally had to take it for my own autoimmune disease. And they're studying that in two large Dutch trials called Reduce PMR1 and Reduce PMR2, looking at both newly diagnosed and relapsing PMR patients. They're also looking at JAK inhibitors like tofacitinib and baricitinib, which is a big improvement because these are oral medications, pills, that are currently used just in rheumatoid arthritis, but they're showing early promise in PMR trials, though larger studies are still needed. So it's exciting that they are finally studying PMR. I'm frankly blown away that it's taken this long to get drugs FDA approved and studied for PMR when it's the second most common inflammatory disease in people over 50. So we have one FDA approved drug, Kevzara. We have Actemra approved for a closely related disease, GCA. Cosentyx is coming down the pipeline, and I'll bet it'll probably get approved sometime in the next few years. Then we have those other treatments coming, and it's a very exciting time if you are newly diagnosed with PMR, that you are not having to face a future where prednisone is your only option. That if you play the right games, run the right bureaucratic games with prior authorizations and approvals, you could try these 3 drugs possibly. If you'd like to know more about how to jump through those loops, just let me know. I've been on the other side. I know how that works. And what's crazy is that of those drugs that I've mentioned, prednisone is not actually FDA approved, yet it's the standard treatment. So the question to bring to your next appointment with your rheumatologist is, now that I've had a trial of prednisone and it hasn't been going well for me, it makes me feel this way and this way and this way, insomnia, bone loss, my metabolism, I've gained weight, yada, yada. Now I have a heart attack. Now I have a heart flutter. Whatever those horrible things are that prednisone is doing to you, am I a candidate for Kevzara or another biologic medication, doctor? Hey, write that question down and bring it to your next appointment. One tip I like to do when I have upcoming appointments, and it's like, okay, I need to remember this question, this question, this question, is that on my calendar appointment in my Google Calendar, in the notes section at the bottom of the Google appointment, I actually write out the questions. So then when I'm sitting there with the doctor, I can just pull out my phone, tap on the actual calendar date when my appointment is on my calendar, and it opens up and it's like, oh, should we try Kevzara for PMR? Hey, that's a great question to ask, but you might not remember in your short 7-minute appointment with your rheumatologist. The treatment landscape for PMR is genuinely changing, and it is an exciting time. But if you're watching this, you're probably taking prednisone. And while you're taking it, there are things happening inside your body that most doctors, even the good ones, aren't warning you about. And it's not because they don't care, but because your appointment wasn't designed for this level of detail. That's why you need to check out my video, The #1 Mistake You're Making with Prednisone. And I believe it is the most important video I've made for people with PMR. It covers the single biggest thing I see prednisone patients getting wrong. And it's already helped thousands of prednisone warriors understand what's really happening in their bodies. If you have PMR and you're taking prednisone, this video is for you. Because the way most people take prednisone, it was not designed with PMR in mind. Here's what most people have been told. Take your prednisone first thing in the morning. Take it with food. Follow your doctor's taper. And that advice is fine for most conditions, just not for PMR. PMR attacks your body at night. The inflammation builds while you sleep, which means by the time you take your standard morning dose and wait for it to kick in, your shoulders and hips have already been aching for hours. You've been fighting inflammation from behind. And the food rule, I'm going to bust that myth today. Because what you've been told is not backed by evidence. And it may actually be delaying when you take your dose, which makes your mornings worse. I'm Dr. Megan, the prednisone pharmacist. I attended a Harvard Medical School conference specifically about PMR and GCA. And I surveyed hundreds of PMR patients before I went there and asked the doctors there the questions that you have. I've also taken high-dose prednisone myself, so I know what it feels like to wake up with the side effects of prednisone. And I know how much difference the right protocol makes. In this video, I'm going to give you the complete picture, the right dose, the right taper, and the right way to take your prednisone for PMR specifically, including 2 modifications that can make your mornings dramatically better. Now, if you're thinking, my doctor told me to take it a certain way, I can't just change things. I'm not asking you to change anything without talking to your doctor. I'm going to give you the information, the evidence, and the exact questions to ask your doctor, because you deserve a protocol built for PMR, not borrowed from a different disease. And later on in the video, I'll give you the prednisone taper chart based on the official guidelines, and you can literally print it out and bring it to your next appointment. Every day that you're taking prednisone without the right protocol, you're either dealing with more pain than you need to or more side effects than absolutely necessary. So let's fix that right now. I call this the restoration framework, restoring what prednisone disrupts, starting with how you take it. Here's the roadmap for today. Let me start with something that might surprise you. PMR is actually one of the most common inflammatory conditions for people over 50. About 745,000 Americans have it right now. And the primary treatment, basically the only treatment most doctors offer, is prednisone. So you'd think we have it completely figured out by now, right? Clear guidelines, clear protocols, clear communication from doctor to patient. And yet, when I surveyed the patients before I went to the Harvard conference, I heard the same story over and over. I was handed a prescription and said, see you in 3 months. That was it. No explanation of the dosing, no explanation of the taper, no explanation of what to expect or what would happen if you flared. And the data backs this up. Studies show that 65 to 77% of PMR patients are still on prednisone a year after diagnosis. And nearly half, about 43%, will relapse in that first year. even when doing everything right. This is not a failure of you, the patient. That is a failure of the system to properly set expectations and provide a roadmap. So that's what this video is, a roadmap based on the actual guidelines. All right, before I talk about the dose and the taper, I want to talk about how to actually take prednisone, the physical action of taking prednisone, because it's not what most people think when it comes to PMR. For PMR, the default instructions may be making your mornings more difficult than they have to be. For most conditions, asthma, autoimmune conditions, allergies, doctors say take prednisone first thing in the morning. That aligns with your body's natural cortisol system, which peaks around 8 a.m. It makes sense. But PMR operates on a different clock. The inflammation in PMR is driven by cytokines. These are inflammatory signals, and the cytokines peak in the early morning hours, between about 2 a.m. and 6 a.m. By the time you wake up and take your prednisone and wait for it to start working, your shoulders and hips have already been stewing in this inflammation soup for hours. That's why morning pain and stiffness is so severe with PMR. That's why so many of you tell me it's so hard for you to get out of bed. So the standard protocol, while it's not wrong, isn't necessarily optimized for PMR. And there are two optimizations that you could try that can make a real difference. Modification 1, the early alarm. This first modification is simple. Set an alarm for an hour before you actually plan to get up. Take your prednisone right then. You can keep a glass of water or water bottle on your nightstand and then go back to sleep for an hour. What you're doing is giving prednisone time to kick in and start working before you actually need to get up. By the time your real alarm goes off to get out of bed, the medication has had an hour to begin reducing that morning's inflammation. Your shoulders and hips will thank you. I've had patients tell me this one change transformed their mornings. They went from being barely able to roll out of bed to feeling like a functional human being by 8 a.m. Modification 2, the split dose. This second modification is for people whose pain is particularly severe at night or who notice their symptoms creeping back early evening or in the afternoon. It's called a split dose. Instead of taking your entire daily dose first thing in the morning, like every other disease, you're going to split it so that you take 2/3 to 1/2, somewhere in that range, first thing in the morning, and then you take the other portion, whether that's 1/3, 1/4, or 1/2, at bedtime or sometime in the evening. So for example, if you're taking 15 milligrams as your total daily dose, try taking 10 in the morning and 5 at bedtime. If you're on 10 milligrams, try 7 in the morning and 3 at night. Though once you get to that point, you're going to have to talk to your doctor about getting 1 milligram tablets or the complications of splitting the dose. You'll have to work that out. A few things to know about split dosing. Some people find it harder to get restful sleep at night when they take prednisone at night because prednisone is stimulating and now we're no longer mimicking that cortisol curve perfectly. But those same people say that now they're actually able to sleep because the pain is gone. So it's a tricky balance between the pain keeping you awake and the prednisone keeping you awake. So if you're going to try this, start with a smaller evening dose and see how your sleep responds. And always run this by your doctor before making this change. One additional possible modification is normally your prednisone prescription is the super cheap generic prednisone tablets that you can buy without insurance for $10 or less for the most part. There is a brand name expensive medication that is specially designed for this situation called Rayos, and it will slowly release overnight instead of hitting all at once so that that dose will not hit and keep you awake. It'll just kind of slowly release, and it's designed to be taken at bedtime and give you that full effect for morning relief. That's another option you could talk to your doctor about. But a lot of insurance companies won't pay for it because it's so expensive and the generic prednisone is so cheap. Now for the food myth. If your doctor told you to take your prednisone with food, they're not wrong to tell you to be cautious because prednisone legitimately does have the propensity to irritate your stomach lining. That's real. But here's what the evidence shows. There's no solid clinical data showing that taking prednisone with food actually is protective of your stomach lining. So if people wait to take prednisone with food, here's what ends up happening. Instead of taking it at 7 a.m. the morning you woke up and rolled out of bed, you're waiting until you get slowly out of bed, you get your shoulders, they're in pain, and you get dressed, and then you make your way to the kitchen and you assemble something to eat, and you prepare your coffee. And by the time all of that's done and you finally take that first prednisone pill, you've been in misery for 30, 40, 50, 60 minutes after waking up. And with PMR, that delay matters. Every minute that you're not medicated, the inflammation has the upper hand and you're suffering. So for most people, the better move is to take prednisone the moment you wake up with just a glass of water, and then eat whenever your breakfast is ready. So if you didn't want to make modification 1, which was to set an alarm and wake up an hour earlier, or do the split dose method, which is, 2/3 in the morning and 1/3 at night, this way is the very simplest modification. It is literally take the pill the second you wake up, and then it will kick in by the time your breakfast is ready. That way you don't delay the pain relief. And there are other strategies that are legitimate for preventing GI side effects. If you're the type of person who's been dealing with GI issues, whether it's ulcers or just acid reflux, what you can actually do to help is to take another medication that is designed to specifically help with that problem, called a PPI. Something like Nexium or Prevacid, pantoprazole, esomeprazole, anything that ends in prazole. They're over the counter. They're easy to get access to, and they will protect your gut lining if that's a problem for you. But for most people, it's not going to be a problem. The exception is if you're actually taking prednisone and an NSAID like ibuprofen, naproxen, Celebrex. That combination will legitimately increase your risk for GI complications and possibly bleeding ulcers that could kill you. And so avoid that combination by not doing this drug interaction. Either take prednisone or an NSAID, but not both unless you've talked to your doctor. So what is the right dose to be taking for prednisone? Because like I said, you could be getting too much prednisone or too little prednisone, and one of them is going to give you too many side effects and the other one's not going to give you enough pain relief. So what do the guidelines actually say about how much prednisone doctors truly recommend? According to the ACR/EULAR guidelines, that's the American College of Rheumatology and the European League Against Rheumatism, the recommended starting dose of prednisone for PMR is between 12.5 milligrams and 25 milligrams per day of prednisone. Now that's a range, and the range matters. Not everyone with PMR should start at the same dose. Your doctor should be matching your dose to how severe your personal inflammation is. They should be testing your blood and checking the markers like ESR and CRP to guide the conversation. So one of the problems I see is patients who are being treated for PMR but are getting a dose of prednisone of 40 or even 60 milligrams a day. These are humongous doses that should be reserved for emergency situations like a related condition called giant cell arteritis or GCA. It's a different and more dangerous condition, but PMR doesn't need that level of suppression. And starting too high sets you up for more severe side effects and a much harder taper later and a much longer taper. The other problem is patients who are started at only 5 milligrams or something less than 10 milligrams a day. This is way too low to actually control the inflammation. The PMR symptoms don't resolve, the ESR stays elevated, and these PMR patients end up going through multiple dose adjustments to actually get the disease under control. If you're within the 12.5 to 25 milligram range, most people will have a wonderful response. They'll go from horrific, miserable suffering to, oh my goodness, this feels amazing. I feel normal again. So if you're started significantly outside of those ranges, that's a conversation worth having with your doctor or rheumatologist. So phase 1 of your prednisone dosing is when we go from really outside of normal cortisol-related ranges back to what's called the physiologic range. Once your symptoms are controlled, and for most PMR patients, the dramatic relief happens within days to maximum of weeks. Then you begin tapering to 10 milligrams a day. The guideline says this should happen within 4 to 8 weeks. So you're not rushing, but you're also not staying at that starting dose for months. The goal is to reach 10 milligrams within 1 to 2 months. And if it takes longer than that, that's fine. But you don't want to just be staying at a high dose for a long time without trying to taper. I want to talk about the 2 biggest mistakes I see. Mistake number 1 is starting too high and tapering too fast. When you're at really high doses, you can drop by 5 milligrams at a time. But once you're getting closer to 20 milligrams, 5 milligrams may be too aggressive for some people. It's really between you and your doctor, but sometimes that's just too aggressive. And it's really not necessarily about a milligram drop. It's more about a percentage of the dose drop. So dropping from 60 to 40 is a 33% drop, right? But dropping from 30 to 20 is also a 33% drop. But that is way too aggressive. Your adrenal glands need time to reset and adjust. Your inflammation needs to be monitored. Rushing the taper is one of the top reasons prednisone patients with PMR relapse. And the second mistake is starting too low and never fully controlling the disease. If your inflammatory markers never normalized, if your pain never fully resolved, the prednisone may have not actually gotten ahead of the PMR. And under-controlled PMR creates its own long-term problems, including the risk of developing that other disease, GCA, giant cell arteritis, which leads to a potential risk for vision loss. So that's why the guidelines exist, not to be rigid, but to give you and your doctor a framework of what actually works. Before I move to phase 2 of the taper, the slower, more critical phase, where most people either succeed or get stuck, I wanted to make sure you have the tool that goes with this. I created a free prednisone taper chart based on these guidelines. It maps out the schedule in a printable format that you can bring to your rheumatology appointment. Click the first link in the description to grab it right now. It's completely free. If you're watching with your phone, there's a QR code you can scan to grab it as well. All right, phase 2. Here's where things get really important. This is the slow zone, and it's where most PMR prednisone warriors hit a wall. Once you've reached 10 milligrams, the guideline slows things down. It says to taper by just 1 milligram every 4 weeks, or you can do it in alternating steps, like going from 10 milligrams a day to 9 milligrams a day, cycling down in increments. Either way, you're talking a minimum of 10 months to get from 10 milligrams to 0, if everything goes perfectly and you don't flare. But here's the honest reality that most PMR patients that I surveyed feel really betrayed about and misled. Most PMR patients need longer than a year to get off of prednisone. The data shows that 51% of patients are still on prednisone 2 years after starting, and 25% are still on it 5 years in. That's not failure, it's just the nature of this disease. But it's also why protecting your body during this time is so important, which I'll get to in a few minutes. The most important principle of this second phase is never taper faster than your body is ready for. Your doctor should be checking your ESR and CRP with dose reductions. If your inflammatory markers are creeping up before you've even lowered your dose, your body's telling you something. Also, and this is critical, there are factors that can predict who might have a harder time tapering. If you're female, if your ESR was higher than 40 at the time of diagnosis, or if you had joint inflammation along with your PMR, research shows you have a higher risk of relapse and a longer treatment course. You need to be aware of what to expect. So let's talk about relapse, because if it's happened to you, I want you to hear this. PMR relapse is not your fault. It's not a sign that you did anything wrong. It's a 43% probability in the first year alone. So here's what the guidelines say to do if you relapse. Step 1, go back up to the pre-relapse dose, whatever the dose was that was working before you flared. So let's say you were taking 10 milligrams and you tried to go down to 7.5 milligrams, which is too big of a jump for my opinion. And then you have a flare during that transition time, then go back up to 10 milligrams and start over with a slower taper from there. Taper back down more gradually than you were doing before. They say you can do it within 4 to 8 weeks, but in my opinion, you need to take whatever time that it takes to get there. And then once you get back to that dose where you had a relapse, restart a slow taper. So what you don't do is panic and stay on that higher dose forever. And what it wouldn't make very much sense for a doctor to do is to escalate you back to a GCA dose of 40 to 60 milligrams, unless there's evidence that you have GCA. Now, if you've had more than 2 relapses, or if you can't get below 7.5 milligrams, which seems to be like the dose that people really struggle at, without PMR returning, or if the side effects from taking prednisone so long are becoming dangerous, the guidelines actually call this refractory PMR. And in those cases, there's now an FDA-approved biologic medication called tocilizumab, and the brand name is Actemra. And it can be added on to reduce your reliance on prednisone so that hopefully the Actemra can eventually kick in and you won't need as much prednisone to keep your disease stable. That's a conversation to definitely have with your rheumatologist if you feel stuck with prednisone. Now, this video wouldn't be complete without a set of warnings that people wish they'd known. Those people who went to the rheumatologist, got a diagnosis, and they said, come back in 3 months, and weren't given any warnings or expectations at all. By definition, if you have PMR, you're over the age of 50. And if you're a woman, which 2/3 of people with PMR are likely to be, you are at much higher risk for osteoporosis because prednisone is stealing calcium and vitamin D from your bones. It's breaking down your bones. And so you need to be taking precautions, protecting your bones, getting bone protection exercises, eating a good healthy diet, and supplementing with calcium and vitamin D, getting tested to make sure your vitamin D is within the safe range. Otherwise, you can lead to osteoporosis, broken bones, loss of height, and miserable complications that are permanent and irreversible. In addition, other things people wish they'd known are that prednisone can cause diabetes because it's stealing chromium from your body. That lack of chromium makes it so you can't use insulin as well. You're having higher blood sugars. This leads to weight gain, hunger cravings, and long-term complications from potential diabetes diagnosis. Prednisone can lead to eye complications like glaucoma or cataracts, and high blood pressure and heart disease like arrhythmias or other heart disease complications. Prednisone is an immunosuppressant, so it can increase your risk for infections like sepsis or pneumonia. Of these, studies show that 65% of PMR patients will experience at least one of these serious adverse events during the treatment course. Broken bones, diabetes, infections requiring hospitalization, or up to 150 possible side effects of prednisone. These are not theoretical risks. These are documented realities, and you need to be aware that this can happen. And if you're like, what is happening to me? Why do I suddenly feel that way? It could be the prednisone. Next, prednisone can mess with your brain. It can actually change your mood, change your personality, make you feel like you're just a passenger in someone else's body. It can cause moon face, a roundness, a fullness, a redistribution of fat from your arms and legs to your face and your belly, so that now you have this big round face and big round belly and skinny arms and legs because now you're losing muscle mass too. So if you're taking prednisone and you're like, wow, I feel like I'm between a rock and a hard place. If I don't take prednisone, my PMR is horrific, can flare, can turn into GCA and lead to blindness. But if I take prednisone, it can cause all sorts of awful complications that can lead to permanent side effects. Wow, this is a terrible, deal to be making, right? They say that taking prednisone is like making a deal with the devil, because you're getting your pain relief, you're getting the use of your arms and your hips back, but you're increasing your risk for so many horrific side effects. Which brings me to something I need to share with you. PMR warriors want to know, is there anything I can do to protect my body while taking prednisone for PMR? And the answer is yes. That's exactly why I created Nutrinizone. It's the first and only supplement for people taking prednisone. After going through prednisone myself, and after years of clinical research into what prednisone actually does to your body's nutrient levels, I discovered that prednisone systematically depletes a set of nutrients, vitamins and minerals that your body needs. Not just calcium and vitamin D, which doctors mention in the guidelines for osteoporosis from prednisone. There are actually 10 or more nutrients that prednisone steals. Nutrinize is the only supplement specifically formulated to give these back, to replenish those depleted nutrients in the right forms and at the right doses. It's not a cure for PMR, and it definitely doesn't replace prednisone, but it helps your body handle the prednisone better. If you want to learn more, there's a link in the description. There's actually 2 bottles. This is the bedtime bottle, and you also get a morning bottle, all for one purchase, a complete supplement system of everything you need while on prednisone. All right, so here are 4 questions to bring to your next rheumatology appointment or your appointment with your primary care doctor if they're the ones managing your PMR. You can write these down or take a screenshot. Number 1. Is my current prednisone dose consistent with the EULAR ACR guidelines? This establishes that you know the guidelines exist, and it changes the dynamic of the conversation. Maybe your doctor hasn't even heard that there are updated guidelines at all. Number 2, are my inflammatory markers, ESR and CRP, normalized? And are we using them to guide my taper? Because if no one is checking your labs, how do you know your disease is actually controlled? Number 3, what is my relapse plan? If I flare when we taper, what is the protocol for me? Get this in writing if you can. Knowing the plan in advance prevents pain and panic decisions. Number 4, given my other health conditions, what side effects should we be proactively monitoring and treating? This is how you advocate for bone scans, diabetes monitoring, eye pressure checks, whatever applies to you. You deserve a doctor who will engage with these questions. If yours won't, or if they say any of this is outside my scope, that's important information about whether you may or may not need a second opinion. If you've been told you'll probably be on prednisone for years, if every taper attempt crashes your symptoms right back, and it feels like nothing has really changed in how PMR or GCA gets treated, I need to show you something. Because something has changed quietly, gradually, and most patients were never told. Not by their doctors, not by their specialists, and definitely not by the system. So if you're stuck on prednisone right now, wondering if this is just how it has to be, this video might completely change how you see your options. Here's the question that started this for me. Why are there millions fewer prednisone prescriptions being written today than just a few years ago? That's not a typo. Millions. If long-term prednisone were still the only realistic option, that shouldn't be happening. For decades, prednisone was everywhere. It was the backbone of inflammatory disease treatment, especially PMR and GCA. But for some reason, in the United States, prednisone prescriptions peaked in 2018. Since then, they've dropped by about 40%, specifically 42%. That's not a small dip. That's not because of COVID. That's a structural shift. And the timing matters because 2018 is also the peak of when I was prescribed prednisone for myself. I was on 60 milligrams of prednisone in roller coasters of high doses and low doses, trying to taper, trying to get my inflammatory disease, my autoimmune disease under control. At the time, prednisone was still treated as something that prednisone patients just had to endure. The side effects, barely mentioned. The long-term risks, almost never discussed. I'm Dr. Megan. I'm a board-certified doctor of pharmacy and third-generation pharmacist. And I didn't just study long-term prednisone, I lived it. High doses, brutal side effects. and the constant fear of what is this doing to my bones, my eyes, my blood sugar, my future. So when I see data like this, prednisone use dropping by 42%, I know it's not happening by accident. Something shifted. And I want to show you what that shift means for you. The first theory of what caused this is COVID. Fewer doctor visits, fewer diagnoses, so fewer prescriptions. And yes, COVID did cause a temporary dip. But here's the key detail. After COVID, most medications rebounded. Antibiotics came back up, blood pressure medications came back up, but prednisone didn't, which tells us this shift was already underway and it stuck. The second theory of what caused this drop of 42%, doctors just switched to a different steroid. So I looked. Methylprednisolone, mostly flat. Dexamethasone, it spiked briefly during COVID because it was the only thing that actually was proven to save lives at the beginning, but then it dropped back. And when you convert all the steroid prescriptions into prednisone equivalent doses, total steroid exposure still dropped by 40%. This wasn't substitution. This was modern medicine intentionally using less steroid overall. I'm so thrilled. And I didn't just see this change as a patient. From 2015 until 2020, I worked as a prior authorization and appeals pharmacist. That's a behind-the-scenes role that most patients never know exists. I was reading the chart notes and appeal letters the doctors submitted, sometimes 50 pages or longer, trying to get newer treatments approved. And even when those newer treatments weren't direct replacements for prednisone, there was one thing doctors documented over and over: what long-term prednisone had already done to the patient. Bone loss, diabetes, fractures, infections, mood and sleep disruption. These weren't theoretical risks in a textbook. They were documented, measurable harm. At the time, there often weren't good steroid-sparing options yet, especially for conditions like PMR. But the message in those charts was unmistakable. Prednisone worked, but the cumulative damage was becoming harder and harder to defend as a long-term plan. So when people ask me what really changed, I think medicine started taking its own documentation seriously. And that gap between recognizing the harm and having better options, that's where most patients get stuck. Medicine knew prednisone was causing bone loss, weight gain, mood changes, sleep disruption, all of it. But for conditions like PMR and GCA, there weren't any good alternatives yet. So patients stayed on prednisone, sometimes for months. When it comes to PMR, usually for years. And here's what no one talks about. Prednisone doesn't just cause side effects. It's doing that by stealing the nutrients your body needs. Calcium for your bones, vitamin D, magnesium, chromium for blood sugar and metabolism, potassium. When I was on 60 milligrams of prednisone, no one warned me about that. No one told me my body was burning through these nutrients faster than I could replace them through food alone. So after I finally got off prednisone and started rebuilding my health, I created Nutrinize. It's designed to replenish what prednisone steals. It doesn't replace your treatment with prednisone. It doesn't cure PMR or GCA, and it's not magic. But if you're on prednisone right now, especially if you're in the waiting period between we know this isn't ideal and here's a better option, Nutrinize is what I wish I'd had. Support for your bones, your metabolism, your sleep, and your body while you work with your doctor on the next steps. I'll link it below if you want to learn more. Now, here's where PMR and GCA patients often feel left behind. They think, sure, asthma and Crohn's disease, they got better treatments. I see the advertisements on TV all the time with the rapid fire side effect list. But what about us with PMR, right? That's what you might be thinking. And I want to be clear about something. I've trained directly with rheumatologists at Harvard Medical School through their continuing education program on PMR and GCA. So when I talk about what's changed in these conditions, I'm not guessing. I'm telling you what rheumatologists are teaching right now about how to manage these diseases differently than they did a decade ago. Here's what changed, and this is big. For the first time ever, PMR and GCA gained FDA-approved treatments specifically designed to reduce steroid use. PMR now has a biologic option for patients who can't taper off prednisone called Kevzara. GCA has multiple therapies designed to get people off high-dose, long-term steroids, including Actemra and others. A decade ago, these didn't exist. So yes, the prednisone data shifted across all conditions. But for PMR and GCA, this isn't just an interesting trend. It's a new category of treatment that didn't used to be an option. Here's the most important shift. Prednisone hasn't disappeared. And for some people, it's still necessary. It's still the most effective thing for PMR. But its role has changed. It's no longer meant to be the destination. It's meant to be a bridge. So if you're struggling to taper off prednisone, if every attempt sends you right back to square one, that's not you failing. That's information. Information that tells your doctor, we may need a different approach. If you have PMR or GCA, this matters because the old story, the one that said, you'll just be on prednisone for years and you have no choice and there's nothing you can do about it, that story is outdated. Medicine moved forward, even if the conversation in your doctor's office hasn't always caught up yet. So if you're on long-term prednisone right now, it's reasonable to ask about treatments designed to reduce steroid exposure. It's reasonable to bring up the fact that you've been on prednisone for months or years and are still struggling. That's not being a difficult patient. That's being informed. And that's exactly what you deserve to be. This video isn't about quitting prednisone overnight. It's not about going against your doctor's plan. It's about knowing that you don't have to be stuck in the past. Medicine changed. Options changed. Guidelines changed. And if no one told you or your doctor yet, now you know. Prednisone saves lives. But if you've ever had to take it, you know that it causes side effects and many changes to your life. And if you are struggling with weight gain, of what to do with your diet, what about exercise? If you have PMR, then I have the perfect person for you today. I have a 77-year-old person with PMR who is actually a fitness instructor with Silver Sneakers. Welcome to the show, Bonnie. Can you take us to that moment at 3 o'clock in the morning when you realized something was wrong?
I can. I can talk about it now. When it first happened, trying to explain it to my doctor, I wasn't even able to explain it. I would burst into tears every time. My husband had to speak for me. I had been dealing with what I thought was a sports injury. I thought I had injured my shoulder. I overextended. I hyperextended because I was teaching some new moves for my class. So I went to an orthopedic surgeon who took x-rays, MRI, did all that stuff. Couldn't find anything other than an inflamed bursa. Gave me a cortisone shot, which worked for 3 days. Then recommended something called a PRP, which is a
platelet-rich plasma.
Plasma. And I did that. And I would never do that again. It was the most painful procedure I've ever had. About a week and a half after that, I went to bed one night. My shoulder was still sore. My hip was still sore. I woke up at 3 o'clock in the morning, a cripple. I was in so much agony, I couldn't move. I was just laying there shaking. And I knew I had to get up because I felt like it was due to the fact that I was laying in bed. So I can't explain how I was able to get myself out of bed because that again was another torturous move. So I was able to get up and stand. The only thing that didn't hurt at that point was the bottom of my feet. And I made myself go into the hallway so I wouldn't wake up my husband. I'm still thinking that had something to do with a sports injury. And I stood there just shaking for over 3 hours. The pain was so bad, all I could do was shake. And after that, I could move an arm about an inch, and then the other arm about an inch. And then, at any rate, through a process of slowly moving certain parts of my body, I was able to kind of relax and be all right after that. I went back to bed, got up the next morning. I don't even know if I told my husband about it yet because I was still stupidly thinking it was a sports injury. Next night, exactly the same thing. Same thing happened at 3 o'clock in the morning. Same procedure. Finally, that I told my husband about it. And he said, well, what could be wrong? And so we did a procedure where I would go to sleep and he would wake me up every 2 or 3 hours and give me a pain pill, and then I would go back to sleep. That actually worked. And I don't know if it disturbed, whatever it did, it worked. I called my doctor the next day. He was able to get me in that day. And I'm really blessed that he was able to have the diagnosis that day, because when I had the PRP shot, the tech that had given it to me, I was explaining to her, why would my one arm and one hip hurt? And she said, that sounds like an autoimmune thing to me. So I mentioned that to my doctor, and his eyes opened really wide. And he said, wow, I'm impressed that she said that. So almost immediately, I think he drew the conclusion. I think I heard him say PMR. Sent me for an immediate blood test, which came back the next day. And I don't know, I'm in Nevada. Quest is where I went to, Quest Diagnostics. And the inflammation test goes up to 99. Mine was over that. So immediately he put me on 20 milligrams of prednisone. That did it. The pain did not come back. He put me on that for 2 weeks, then dropped me down to 15 milligrams. Same, no problem after that. A week later, he tried to drop me down to 10, and I couldn't tolerate 10. The pain came back. So he put me back on 15, and I see him again next week. And he wanted to wait to do any more changes until I see him again. So that's where I am today.
Wow. That is so stunning how sharp and quick and instant the pain was for you.
Yes.
And how you were able to somehow function your way through that horrific experience. But I get why you would blame it on a sports injury. Like, that makes perfect sense. You're a very active person.
Right.
You must have injured yourself. Like that. I don't think that's stupid at all. I think that makes perfect sense.
In hindsight.
In hindsight, right. Exactly. What you wish you could have known before, but
Sure.
yeah. So that sounds awful. I'm also very impressed with your person who administered that tech, that they were able to say, that sounds autoimmune. And what a blessing.
Yes, very much blessed I am.
Yeah, that is fantastic. Okay, so what did you notice when you dropped to 10 milligrams? What was that thing like, oh, this isn't working for me? What, can you describe that in a little more detail?
It took about 3 days. The first day when I woke up after going to 10 milligrams that morning, the next morning I woke up and I was a little stiff is all. The next day, the arm started just a little bit of pain. The third day, the hip and the arm, my pain level went up to about an 8. So I immediately contacted my doctor. He said, go back to 15. And that's how it was about 3 days before the pain came back.
Okay. So it just kind of steadily got worse over those 3 days.
Correct. Yes.
Okay. Gotcha. So for you, when would you call the doctor in the future? What would be the thing that's like, oh, I better talk to my doctor?
It would be if the pain returned. I've contacted him 2 or 3 times since watching your videos and suggested that instead of going from 15 to 10, I go from 15 to 12 and a half. He said, stay on 15 until I see you again. Oh, okay. And so that's where I'm at. And then I contacted him again when I learned that the most rapid loss of bone, what is the word I want to use?
Density?
Yes, is in the first 12 weeks. And I'm in week 6 now. So I told him that. And I said, should I be taking, in addition to the calcium and the supplements that I'm taking from Dr. Megan, should I be taking something stronger? And he said, we'll talk when you come in. So he's really actually very open-minded. I'm always asking him questions. He's really pretty open-minded, but I think he wants to just have it all there where we can talk about it. So
awesome.
Yeah.
Sounds like a great doctor. Some doctors are totally unfamiliar with PMR, don't know how to deal with prednisone. So it sounds like he's at least aware and he's trying and he's working with you. And that's all you can really ask.
Yeah. Yes. I'm very happy with my doctor.
Okay. So you mentioned my supplements. What did you discover? How did you find them? What were you looking for, thinking?
The first time I watched one of your videos, I watched several. I mean, I've probably watched 50 of them. I don't know how many you have, but I watch every one I can. And you had mentioned, I watched the one about what to do so you don't get moon face, obviously vanity's part of it, but also, I don't want to lose my spine and I don't want to lose height at my age. So I ordered your supplements mainly because I wasn't sleeping. And I was a pretty good sleeper before that, 7, 8 hours a night. Almost within 2 days of taking prednisone, that went down to 3 hours a night. And that was about a week. And I think I ordered the supplements pretty early in on mine. It might have been a week, I'm not sure. But with, again, the second day taking them, I was able to sleep. Last night, I slept 7 hours and 43 minutes. So, and that's normal now for me again. So that's the biggest, for me, it's too early to tell, obviously, for the bone loss and other issues I'm not having. I'm not gaining weight. I'm actually losing weight. And I think that's helpful because of the supplements. And I am aware of leptin and what it does to your body, and that replacing it can only help. And I don't really have any cravings. I mean, every once in a while, I'll think I want something, but when I go to take a big bite of a candy bar, I'll look at it, I don't want it. So I don't really crave, I don't have any food cravings. And I think that's due to the Nutrinize. And we may get into it later, I'm not sure. I was taking semaglutide, and I'm tapering off that now. It's almost like I take 2 something. It's not much I'm taking. But while you're taking that, you're just not interested in food. It's not like it kills your appetite. You still get hungry. You just don't care. You're not hungry. You don't eat. So maybe there's some of that residual effect. I'm not exactly sure, but I have no food cravings and I'm sleeping well. And my moods are stable. I don't think I haven't gone berserk or anything. I don't feel I've had any mood swings. And I do tie all that into the supplements that I'm taking. I really think that has stabilized everything in my body. And one hint I will probably go into at the end is that if I had anything to advise people who are going to be taking prednisone long term, do not wait until you have symptoms to start caring for your body. Start taking supplements immediately. Start changing your diet immediately. Don't wait. Don't wait until you get other symptoms. And that's my biggest takeaway from that.
Fantastic. Okay, we've got a lot to unpack in what you just talked about. Okay, so when you're talking about my supplements, I'm just gonna show what it is. It's Nutrinize Zone. We've got the morning bottle, the bedtime bottle. So that's what she was talking about. I want to dive a little deeper into cravings and semaglutide. So you were taking that long before you started prednisone.
Yes.
Let's talk about that because it's new. I'm not aware of any studies of people taking prednisone and GLP-1 agonists like semaglutide. And so it's really just people like you who are doing the combination who we can learn from because there's nothing else where we can learn it at this point. And when I was at Harvard, they did a little survey of the rheumatologists in the room and it said, who do you think should be prescribing these weight loss medications? Should it be us, the rheumatologists, or should it be the primary care doctor or someone else? Because we're the ones prescribing prednisone that's causing weight gain. And the underlying thesis of that was it's safe to be prescribing it along with prednisone. So you were already using it before starting prednisone. Did you even talk about that with the doctor? Hey, I'm on this. And is it okay to take prednisone, or is it just kind of like that topic didn't really come up? We had all the other things to deal with, or what do you think about that?
That was one of the first things that my doctor mentioned. He said, tell me everything, all the supplements you're taking. Of course, I was taking a bazillion because I'm into health. He said, and I told him what they were. He said, I want you to stop them. He said, I believe that the semaglutide you can keep doing that. There's no in his opinion, there was no interaction between semaglutide and prednisone. And in fact, I can't quote the specific studies. I don't even know if I should mention it. What I have heard is that semaglutide is good for your heart as well as weight loss. It may be good for your kidneys and liver. And so he feels, I mean, I only wanted to lose 15 pounds, but I lost more than that, which I'm happy about. And again, I'm tapering down because I think my BMI now is 20.9 or something. So it's a good BMI. And I feel better. And I exercise still. I didn't cut out my exercise. And he believed that semaglutide and prednisone together would not have, one would not impact the other. And
Perfect.
Then I don't see any problem.
Okay. That is really helpful to hear your perspective as someone on both semaglutide and prednisone. So let's talk more about your experience of semaglutide before prednisone. Just what was it like getting it prescribed? How did it feel giving it to yourself? That type of thing.
Okay. I'm very needle phobic, so I was really concerned about that. But I'm vainer, I guess, than I am needle phobic. So, at any rate, my doctor gave me the prescription, and when I took it to my local CVS, they said, "Well, it'll be $1,000 a month," and I said, "No, I'm not that vain." So I was able. There are a ton online. You can find people or companies who will prescribe it for you, and I found a company. I don't know if I should name it. But
Don't name it, but
I found a
but
company
people
that,
can find them.
yeah, there's a bazillion of them. And I found a company that did it. You have to go through like a telemarketer, telehealth
Telehealth.
visit. And I did. And you have to enter information. They approve you or not. And then they send you they tell you what you will be getting. And they sent it to me. And when I first saw the needles, I kind of freaked out, but my husband helped me and did it in the arm. And the thing, I've never had to do a self-injection. And I'm thinking it's like you're going to get a flu shot, which to me, the needles are huge. They're not, but to me, they are. So anyhow, the needles they send you, I could barely see the needle. It's like a hair. And when my husband did it in my arm, I'm not kidding. I didn't even feel it. There was no sensation of a needle going in your arm. There was nothing. So my first shot, you do one a week. And you don't feel anything. It's not like I'm old. So back in the old days, they used to give you diet pills, which was just basically amphetamines, I think. And they really worked well, except you were hyped up all the time. You don't feel anything. There's no sense of energy, nothing. It's just, I think by the next day, I did it at night just to make sure I would be okay for my class. I had to teach the next day. And I felt nothing. I got up. And I just felt like I was normal. And by the time I got home from my class, I didn't eat anything. I wasn't hungry. You have to almost make yourself eat something healthy, not because your stomach isn't saying it's empty, but because your brain says, oh, well, you don't really feel like eating. It's wonderful. I have to say it's wonderful. But you have to make yourself eat. You have to make yourself eat healthy foods. And I know some people can override that and still continue to eat poorly and maybe not do as well. But this medication to me is wonderful because you just never think about food. You don't think about food. So that was the biggest takeaway for me. And it was a slow process. I think I started in March or April. And through like August, I lost the 15 pounds and then I lost another 5 pounds. And now since I've been diagnosed with PMR, I watch every bite of food I put in my mouth. And I don't eat salt. I don't eat sugar. I've never drank caffeine. I just never have. Carbs are out. And I'm okay with it. I'm okay with it. And so I've lost another 3 or 4 pounds in these 6 weeks. So I'm very happy so far, even though I'm on prednisone. And again, maybe I'm sure I still have some residual semaglutide in my system. Certainly it's like an eighth of as much or a tenth as much as when I started, but it's still there. And I think this might be my last month on it. So we'll see. But I feel like by that time I will be perfectly trained and my eating habits have changed significantly. And I'm okay with that. I'm not depressed about it. I'm okay with it.
Wonderful. Okay, so I love hearing how it's felt, that the needle phobia was not as big of a deal as you thought it would be.
Not at all. Yeah.
Yeah. And that you've been able to lose the weight and change your diet. And that when you're off of it, keeping that dietary change is what's going to be the most powerful way to maintain your health.
Correct.
So what are these dietary changes you've made?
For me, I never ate like a lot of salt because my husband didn't like salt that much. So I always use a fairly small amount of salt. I've cut it out, no added salt. I don't add salt to anything. If we eat in a restaurant, even though I order something plain, I know there's probably salt in it. So I'm careful about that. No salt, no added sugar. I'm learning to cook I've just got a bag of cellulose because I tried stevia and it was too bitter. So I'm trying cellulose. I will also try monk fruit because I make pudding, which satisfies if you just kind of feel like you want something sweet or a dessert or something. So I make pudding, and I originally did the sugar-free pudding. And then I was horrified when I read about maltodextrin because maltodextrin spikes your blood sugar more than table sugar, more than cane sugar. If you watch, in every single box of sugar-free pudding I bought the first ingredient was maltodextrin. So toss that away. So I made some the other day with stevia, and it was a little bitter. So now I have cellulose, I think it's cellulose. I'm going to try that to make pudding.
Very nice. So that's what's getting you through when you need a little something sweet.
Yep.
Um, what about like what is your main course? Like what do you eat?
Well, I'll tell you what I started with for breakfast. I've never been big on protein. And it's not that I'm a vegetarian. I'm not vegetarian. There's not a lot of meat I like. So I bought lobster. I'll eat lobster. I'm from the Midwest. I'm born in Indiana. So we like ground beef. I'll eat ground beef. I'm not real big on other meats. So what I found I do for breakfast, when I first started taking prednisone, I thought I better take it with food. My doctor recommended that I do. So I naturally kept waking up at 3 o'clock in the morning. So I get up at 3 o'clock, take a half a cup of cottage cheese, fourth of a cup of pumpkin seeds, 2 tablespoons of Parmesan cheese, and that's 23 grams of protein right there. And the only iffy thing, there's a little bit of salt in the cottage cheese, but not a whole lot. And Parmesan cheese, two tablespoons of Parmesan cheese has protein in it, as do pumpkin seeds. So that gave me 23 grams of protein to start my day. I did that every day for the first 4 weeks. I'm getting a little tired of that, so I might switch to yogurt. But today I did yogurt, and I think I did, I can't remember what seed I used today, but I'm trying to do non-meat things. I do eggs sometimes, but one egg only has 6 grams of protein, so I don't want to eat 4 eggs in the morning. And then my main meal at night, I trade off. Like I will make things, my husband eats, if I'm eating something, he'll eat something. Sometimes I make us separate things because I'm an amateur gourmet cook. I love to cook. So it's kind of changed things for me on that level. But I will make some form of protein. It's usually fish, some form of meat. Like I'll eat chicken. I like chicken. I'll do some chicken and all kinds of fish, something with ground beef. I'll do a burger, but I'll just, cook the burger itself. And it's the very lean ground beef. And I'll eat that. And then just vegetables. I no longer do, excuse me, I don't eat any pasta. And I know a little bit is okay, but right now I want to stick to none to see how that works out. I've just bought some one carb bread, which I actually like. So I can eat things on that. And this is all new to me because I've never tried to eat this healthy. I mean, I've tried to eat okay, but I've never tried to be particularly healthy. So now again, I will eat a piece of meat. I'll try to have 2 or 3 vegetables every night when we have our main meal at night. I've always drank caffeine-free drinks. I've always drank caffeine-free drinks, but now I don't even drink Sprite. I drink caffeine-free tea, which I do during the day anyhow. My lunch is just kind of a grazing kind of thing. Sometimes we'll just graze I'll have a bowl of dip and I'll have all vegetables. We'll just dip our vegetables in that and do that for lunch. And then again, if I feel like I want something at night, I allow myself, this is really silly, but I love pretzels. I'll allow myself 3 pretzel rods. They're the long, thin pretzels. 3 of those. And I'll eat those at night and they work. I love that. That satisfies whatever need I have for carbs, I guess. And so anyhow, it's worked out well for me. It sounds like a boring diet, but I'm really happy with it. I don't have to think much about what I want to eat. And when I get tired of like cottage cheese and pumpkin seeds, I'll switch over. Like I had yogurt this morning and blueberries, yogurt, blueberries, and walnuts this morning, which is a really healthy alternative. Greek yogurt, only Greek yogurt, blueberries, and walnuts. So that's what I started on breakfast today. And I may do that for another 4 weeks. I'm not sure right now.
Wow, that is great. I appreciate how you've kind of acclimatized to your new diet, that you're just used to it at this point, that it's something you can do. It's easy, you said, and that you're really prioritizing protein because prednisone can be stealing protein, making you lose muscle mass, and the semaglutide can do the same thing. So it's fantastic that you're prioritizing those to protect yourself from that possible complication of both of those therapies. So
I watched your videos.
good job implementing exactly what I mentioned. So good work. Okay. So we've talked about what you're eating. Now let's talk about your expertise before all this went down. You're a Silver Sneakers instructor.
Yes.
And what are you doing now? And then talk us through where you came from and then what you do now for your exercise while on prednisone.
I started teaching Silver Sneakers about almost 6 years ago now because we moved to Nevada and I wanted something to do here. I didn't know anyone. So I've exercised most of my life, but I used to run. And when I lived in California, I belonged to gyms there. But in Nevada, I joined a gym and they needed instructors. So I thought, why don't I do that? So I was trained and I started teaching silver sneakers. And I've been doing that again for the last 6 years. When the morning, it's when I woke up at 3 a.m. and all that pain, I was scheduled to work the next day. And I did. Because as I say, after about 6 in the morning, when I started slowly moving things around, I was able to move normally for the rest of the day. So I taught my class. I didn't change anything. I didn't change any of my exercises. Let me take back on that. The first couple of days I did because I had not yet been diagnosed. So my arm, I still was not able to move my arm. And my class knew that. I just said, I have an arm injury. I can't move my left arm. So, but you do. So that was my one. By the next week, I had all the pain was gone and I was able to do all my normal exercises. Silver sneakers is much gentler on the body. It's created for people 55 and older. And I have several people in my class who are recovering from hip surgery, shoulder surgery, backs, all kinds of different knee surgery. So you have to be sensitive to that. All of our exercises have to take that into account. That's why I think this would be perfect for anyone with PMR, regardless of your age. You don't have to be 55 to take my class. It's just if you're 55 or older, most insurances will cover it. So the class that I teach, we have a 10-minute warm up. We warm up, we stretch our bodies. Then we have about 10 minutes of what we call, you do your cardio. And the CDC has said 10 minutes a day is all you need for cardio. If you can get those 10 minutes in every day. I teach 3 days a week. Sometimes I'll do a fourth by myself at home. That's all you need for cardio. You don't need hours and hours of cardio to help yourself. We do 10 minutes of cardio. After that, everything we do is muscle work because we don't want to have sarcopenia. Older people lose muscle mass faster than anyone, and you don't want osteoporosis. So the cardio takes care of the osteoporosis, and the weight work we do and the band work we do takes care of the sarcopenia. And we do that for about 20 minutes. We use weights and we use bands. And then we have a 10-minute stretching cool down. So it's 10 minutes warming up, 10 minutes cooling down, and everything in between is to treat your heart, your bones, and your muscles. And I think it would be excellent for people who have mobility issues of any kind, but particularly PMR, because some people do all of the exercises seated. Some people do it seated partially, standing partially. We have all different levels of fitness in my class, as does every Silver Sneakers instructor. You have all different levels. So I have not changed anything that I teach in my class. I have focused more on the cardio, not because of for heart so much as for bone. And because people believe that, well, I can go swimming and that'll take care of my bone loss. No, it won't. You need weight-bearing exercise. So I tell my students, stomp around your house, march around your house when you're not here. If you're not going to work out that day, just stomp around. You don't have to be in a class to do that. Any weight-bearing exercise, you're going to tear down that bone and the calcium's going to run back in and build it back up. So I tell them this now, mainly because of my injuries, but also because I don't want anybody to have bone loss or sarcopenia. So that's what I do. I haven't really changed anything from my class.
I love that very simplest of all exercises. Just stomp around your house.
Yeah.
Like that's so simple.
Yeah.
Unless you have other impairment, like
Sure.
anyone can do that. You're going to be walking around your house anyway.
Right.
Just like put some impact into it. That's
You
so
can do it seated.
simple. Yeah, you can do that seated. Like pound your chair.
Yeah.
You know?
Stomp your feet when you're out sitting.
Yeah.
Yeah. So I really think that maybe because I've always, I've been teaching for so long, I didn't really impact my level of exercise. I just keep doing it. I keep doing it and I feel good about that. So, and I'm 77 and I get around really well. So I don't want to lose that.
Yeah. You got to maintain that. Exactly.
Yes. Yeah.
That is fantastic. So, okay. How would people find Silver Sneakers? How do you access that?
You can look it up online, but the easiest thing to do is if you have a gym in your town, just call them and ask them if they take Silver Sneakers. I think most gyms today do. There may be some that are more focused on other areas like bodybuilding and something like that. They may not have instructors that teach classes. Most gyms that have classes of any kind will include at least one Silver Sneakers class. You can look it up online. Silver Sneakers has a website. You can go there, put in your city, where you live or zip code. I'm not sure exactly how you do it. And they can tell you the gyms in your area that accept Silver Sneakers. If you're over 55, I think 95% of insurance companies cover it for you. You don't need to pay anything. So you don't need to pay your gym membership. They pay it for you. Under that, I'm not sure if it's medically recommended that you exercise. Maybe your insurance would cover it like they cover physical therapy. I'm not really sure. But I know with Silver Sneakers, it's covered by most insurance. Most gyms accept it.
Wow.
So, yeah.
That is so fantastic that it's a covered benefit for most people. And if you have PMR, you're over 50. So like you can't have that diagnosis without it. So basically, most people with PMR can benefit from this
Correct.
amazing opportunity. I had heard of Silver Sneakers, but I hadn't heard that it's this widespread and this easily accessible. So this is really cool. Fantastic resource to know about. I really didn't know that well. What about, you mentioned your sleep, that with the Neutronize, you're able to get better sleep. Is there anything else you're doing to protect your sleep? Like, what is your sleep routine like? How are you, optimizing that?
Your directions say to take it about 30 minutes before you're ready to go to sleep. What I have found, that's exactly correct. I have taken it in the past, like earlier, and then I'll mess around. I'll get up and do stuff and blah, 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 blah. And then I'll come back to bed and I'll think, oh, okay, well, then I'll have to lay there for a while for it to actually start working. And I think I did that one night, and that's one night in 5 weeks or however long I've been taking it. One night, I only got 3 hours of sleep that night. After that, a second night, I fell asleep and I woke up and I thought, gosh, it's not really working. And then I happened to stand up to go to the bathroom. They were laying right there on my nightstand. I had forgotten to take them. So I did take it and it worked perfectly. My sleep routine is I'll go to bed and we do reading. My husband and I will read whatever I want to do. I'll watch a movie sometimes. And then about a half hour before I'm ready to go to sleep, I'll take my Neutronize. And I'll just, the moment I can tell, my body knows when it's time to close the eyes. And I will close my eyes and I drift off to sleep. And this may seem odd to people, but I used to wake up a lot, even though I slept well, I used to wake up a lot during the night. And every time I woke up, just because I was awake, I'd just go to the bathroom. Not that I had to, but I would. 2 or 3 times a night. I never wake up with Neutronize. I never go to the bathroom anymore in the middle of the night. I only go to the bathroom when I wake up. So I don't know why. I don't know what's changed in that area, but I seem to be having more deep sleep than I was even before I was diagnosed with PMR. And the only thing I never took melatonin or anything before. So maybe, I don't know, maybe that whatever's in it, it works. It works for me. I'm sleeping better and I'm more rested than I ever was. So that's it.
Wow. That is fantastic. That's so good to hear that you're getting restful sleep, that the 30 minutes is right, because that's what I read in studies, but I haven't actually talked to anyone to for sure hear your experience, knowing that is actually perfectly right for you and your biological situation. Awesome. Okay, so being put on prednisone for me, like I was the only person I knew who was put on it. I think you mentioned that you're the only person you know who's been on it. So it's kind of a lonely thing unless you find support. So what have you done, like find support with other people with prednisone?
Well, I want to back up a little bit. So I did find one other person I met at an event I was at. And this man, he walked with a cane, but he was very healthy looking. I mean, he's in his late 60s, I think. And he had been on prednisone for 40 years. He was taking 60 milligrams of prednisone every day for 40 years. He had no moon face. He had no belly. He was thin. He had no buffalo hump. He had none of those obvious, giveaways. And I asked him, how did you accomplish that? And he said, at first he became vegan. He felt that was the biggest contributor to his overall health at that time. He had myasthenia gravis. He still has it, but again, he became vegan. And he said he did that for about 4 or 5 years, and he tired of it, as a lot of people can. And then he started gradually introducing other things. He still doesn't eat any carbs, sugar, salt, or anything like that. And that's the only reason he felt that he was able to get to the point where he is today, which none of the obvious physical, outwardly physical side effects. The one he did have was bone loss. He wanted in his spine, and he needed surgery, spine surgery several years ago, and he could not find a doctor that was willing to do it because of the condition of his bones. He finally did find, I don't know how, he finally found a doctor that was willing to do it, had the surgery, and he's better for it, he said, but he has several pins in his spine, and they will occasionally, I don't mean to laugh, but he did. He said they kind of pop out every once in a while, and he kind of just pushed them back in. One time he had to, I know, he laughed about it. But he did have to go back in, I think, once again for surgery to have it reinserted. But he just says he's come to expect it now, so he's not horrified when it happens. And he's not, he's still tallish. He's not like a shrunken human being at all. So I just told him how amazed I was. I gave him information about you, told him to go to look up the prednisone pharmacist, Dr. Megan. He said he was going to do that. Another resource that I have is Facebook. You had some posts on Facebook, and once I saw your post there, of course, everything starts popping up, like all these support groups. I probably belong to 15 of them now. That is the most helpful thing I've ever had besides your videos. All of these support groups, it's real people giving their real responses to things. And some of them, it reinforces how blessed I am every single time I get on there, because so many people have so many horrible side effects. And I don't so far. Again, I'm in week 6, but I'm trying to prevent them, not just wait until I get them and then try to fix it, which I think is the most helpful for me.
That is such an honest perspective that Facebook support groups, I have found incredible people there. They are so willing to share. They're so generous with their experiences and their time to share. And so I second that. And then what you just said about preventing side effects is so true, because that bone loss, that muscle loss, all the complications, diabetes, heart disease, are a lot easier to prevent than to treat. Once those bones break, it's really hard to get that spine to grow back again. Like it doesn't happen. So you had mentioned earlier that you're talking to your doctor about getting on medication for that. And so I want to dive a little deeper. So prednisone causes this bone loss, leads to osteoporosis, broken bones, like you illustrated with that story of that man. But in you specifically, this is what I'm seeing. Mm-hmm. You have PMR, so an inflammatory condition, which increases your risk for osteoporosis. Mm-hmm. You're over the age of 50. And so as a woman, that's your third factor, you're most likely to have osteoporosis, more likely than men, because of being postmenopausal, losing estrogen. You're on prednisone, you're lower weight. You said your BMI is 20, and those are just 5 of the factors. I haven't seen a DEXA scan. I haven't seen other things. All of those are increased risk for osteoporosis. So making it clear to your doctor, I want to take action now, is so wise. That, like you said, the bone loss is the most dramatic in those first 3 months. So preventing it from getting worse. Mm-hmm. So when they look at the osteoporosis guidelines and it talks about some of those factors I've considered and then a few more, who is a candidate for these medications? You are definitely a candidate. So bringing that up with your doctor, it sounds like you are a self-advocate. You're not afraid to bring things up with your doctor. So do you have any questions or concerns, or you want to elaborate on what you think about those medications?
Well, the only one I was familiar with is it Fosamax?
Mm-hmm. Yeah,
Fosamax. I mentioned that. I said something like Fosamax, and again he said, "Wait till I see you." But I also ran across something. Is it called a FRAX score?
FRAX. Yes.
I'm with 72% of having osteoporosis in the next, or broken bone in the next 10 years. 72%. The only risk factor. I'm a woman, and I'm a certain age, so it's not my lifestyle. It's not anything else. They just said my FRAX score was 72% of a sure thing that you're going to have a broken bone in the next 10 years. So I'm going to bring that to him. I'm going to show him. I got to bring, and he's really good. He allows me to do that. He's allowed me to do that with other issues I've had. I'm going to show it to him. So I believe that I need some. And I know a question that I do have. Fosamax, I think, is the only thing I'm aware of. Are there any other drugs that are as good or would be as helpful?
Yeah. So Fosamax is definitely the most well-studied, the most common medication. The generic name is alendronate. And like you
Okay.
said, it's once a week. And what's tricky about this medication is it's really poorly absorbed. And
Okay.
so if your doctor were to prescribe it, you would want to take it first thing in the morning with a tall glass of water, sitting upright and not eat anything else for at least
Okay.
an hour after.
Okay.
And that hopefully will make it so you can actually absorb it and have the benefit from it. If you were to take it with everything, a full meal, like the absorption would be so much less and it wouldn't be very helpful for you. So just that once a week, you just wait another hour before everything else in your
Sure.
routine.
Good to know.
So, yeah, it's really helpful. There's also other medications. There's injectable versions of medications like Fosamax. There are other medications that work in a different way to support the bones, but the guidelines recommend Fosamax, that type of medication, as the first line. So,
All right.
you're right to be asking for that first.
Okay.
So, if that doesn't work for you, if you can't tolerate it, there are lots of other options.
All right. Good to know. Thank you.
Yeah. Any other questions about your experience on prednisone? Any other concerns that came up in your journey thus far?
I think I told you about the maltodextrin. I found out about that. Do not eat sugar-free stuff. Don't do it. The takeaway for me is do your own due diligence. At this point, and maybe I'm wrong, but I feel like I know more than my doctor does about prednisone and PMR because obviously he's my primary care doctor. He covers everything, and I'm totally focused on the one thing. And doctors are doctors. And I feel like it's up to me to do my due diligence and research everything I possibly can about this. And therefore, I'm the informed consumer. And my doctor works for me. So I want him to know that this is my expectation. I don't want to be a cripple. I don't want to lose bone, muscle. And he has the ability to help me on that. So due diligence, that's my most important advice for people.
That is fantastic advice. And I have a free resource for anyone who wants an easy way to do your due diligence, and it's the prednisone checklist. I go through all the tests and things you can do on your own, things you can do with your doctor, and it'll be free. You can just click the link below, and it's got all of those things that you can do your due diligence with to make sure that you are preserving your bones, your muscles, your heart, your eyes, all the things that prednisone is affecting. That is
Right.
a fantastic, fantastic thing to tell people about. Okay, so I'm going to do a quick lightning round
All right.
and you can just answer like one word or one sentence, okay? So,
Okay.
what is one exercise you will keep forever?
One exercise that I will keep forever. Well, I've just started Tai Chi, so I'm kind of leaning that way. But I think the best exercise I do is either marching in place when in my class. You can walk, but you can't stroll. You have to actually walk and pound those feet. So that would be the one I would never give up because that maintains your bone density. Walking, marching, doing jumping, if you're able to. Not all people can, especially older people with bad knees, hips, whatever. Or if they have osteoporosis, they have to be careful of that. But their doctor will tell them if they can do that level of exercise. Jumping is fabulous if you could do it at our age. So that would be my most important thing.
I love that. What is the one food swap that has made the biggest difference for you?
For me, it's cottage cheese. I just, instead of having, I don't know, whatever I used to have for breakfast, which would be biscuits and gravy because I love them, which is totally probably 98% salt. I don't care. I had some yesterday anyhow, I'll fess up. But that's once in 6 weeks I've had it. So I've swapped out like high protein cereal, which I used to eat, but then I read maltodextrin is the number one ingredient. So I won't eat that anymore. And I really like yogurt and cottage cheese. If you had asked me 6 months ago if I would eat yogurt, I said that will never go in my mouth. But I've learned that I can buy a vanilla Greek yogurt and it's okay. I'm okay with it. I put other things in it. Blueberries and walnuts works for me. So I would say swapping out no protein really for breakfast for dairy products, cottage cheese and yogurt. That's helped me the most.
Fantastic. What is one question every PMR patient should ask their doctor?
Why am I on it and how long do I have to stay on it?
Yeah, that's a great one. How long you're going to be tapering and everything like that. Great question. Okay, so just a reminder to everyone, this is her personal experience. This is not medical advice. This is fantastic advice, but it's not medical advice. It's her personal experience. Make sure you discuss with your doctor exercises, your diet, your supplements. Make sure that they're safe for you and your personal situation. And get access to silver sneakers. Like, wow, I had
Absolutely.
no idea that resource existed. I think get in touch with your local gym or your insurance company to find out the easiest way for you to access it.
Right.
All right. Thank you so much for joining me today, Bonnie. This has
Well,
been a privilege for me to really hear from a real person who not only is on prednisone, is also dealing with PMR, a long-term inflammatory condition, has taken semaglutide, and is a fitness instructor. Like, you're an amazing resource for so much experience. And so thank you for joining me today.
you're welcome. And thank you. Oh my God, you saved my life. So thank you. I'm not exaggerating.
Well, I'll let you keep elaborating there.
You have. Thank God I found you. I do. I thank God I found you. So much information. And every single website I go to, I say, go to YouTube, find Dr. Prednisone Pharmacist, Dr. Megan. Go there, go there, go there. Every single time I can, I put that out there because I'm that impressed with your obvious knowledge and your dedication to prednisone. Oh my gosh, information. I'm very thankful I found you.
How did you find me, by the way?
Well, as they say, I had, as soon as I found out my diagnosis, I went online to look to see, because there's support groups for everything. I think hangnail people have support groups. So I looked online and the Mayo Clinic came up. They have a support group for polymyalgia rheumatica. And so I went there, and one of the articles I was reading, I don't recall the name of the person who did it, but they put a little clip of something about, I don't know if it was about prednisone or PMR specific. I'm not exactly sure, but took me to YouTube. And once I was there, I was like, hallelujah, all these different information about prednisone and PMR, and of course, other diseases, but mainly about prednisone. But there is so much information about PMR and so much information about prednisone by itself that it just opens up the door that you need. It tells you everything you need.
Oh,
So I found it.
well, thank you so much, Bonnie, for those kind words, because it's hard to get people to talk about their experience on prednisone, because for a lot of people, it is so life-changing, and it changes your appearance, it changes your personality, it changes so much about you. And when I was on prednisone, I didn't want to be on a camera. So I get, for so many people,
Yeah.
they're afraid to share like you did, and
Yeah.
how you have such a powerful story to share. So thank you so much. This is Dr. Megan, the prednisone pharmacist, and I'm excited to bring you today a prednisone warrior who is taking prednisone for something I never heard of in pharmacy school. It's called PMR. That's like Peter, Mary, Ruth. Polymyalgia rheumatica. I never heard of it in pharmacy school, and it's not on a lot of lists for why people commonly take prednisone. But I've found that there are thousands and thousands of people suffering every day with PMR who have to take prednisone. So that's why I'm so excited to have Diane here on the Prednisone Warriors with Dr. Megan YouTube channel, because she can share a perspective that no one ever taught me in pharmacy school. All right, Diane, I'd like to introduce you. Please tell us, what is your prednisone story?
Well, I was 2 years ago, I was playing with my grandchildren in the pool, and I was throwing them in the air and bouncing up and down with them. And the next day, I woke up in horrific pain. And I literally thought I had just sore muscles and had overdone it. But 3 weeks later, I still had the same pain. I couldn't turn over in bed. I could not hardly dress myself. I couldn't pick my legs up to put my feet in my shoes or my pants, my socks on. I couldn't lift up over my head to take your shirt off. Putting on a seatbelt and putting on a bra were horrendous. I had to do everything from the front, and I can't even explain the pain. I went to the doctor, and even just to turn over on the table in the doctor's office caused me to scream out in pain, and I'm not a screamer. It was really, really bad. So she, at the time, gave me, oh my goodness, I'm so sorry. There you are. She gave me a shot of prednisone at the time for the pain, and then told me that I would probably be fine to take Tylenol and whatnot, because she thought it was probably fibromyalgia or some kind of myalgia. It did not go away, and it kept getting worse. So I went, referred me to a rheumatologist. And this rheumatologist did a bunch of tests on me, physical tests, not blood work or anything like that at the time. But she said, by looking at you, because it was all in the shoulders and it's all in the hips, that I probably had polymyalgia rheumatica. And it is typically women over 50 of European descent, of all strange things. My mother's from Liverpool, and I fit all the bill. So she put me on 20 milligrams of prednisone right then. And I started having regular blood work done to check my CRP levels, your C-reactive protein. And I was supposed to get down under 10 in order to be getting better. That was in July of 2019. I am only now better. This lasts, from what I'm told, for anywhere from 6 months to 5 years. It's not terminal, it's not permanent, but it is debilitating. But it also has a side effect for some people called, I think it's GSA or something like that, where you can actually go blind. It affects your vision. So you have to have regular checks with your ophthalmologist as well as your blood work constantly. So that's I guess the best way I can describe it.
Wow. So just for everybody else's sake, knowing when it is right now, it is August 2021. So that's over 2 years that you have been on this roller coaster of pain and prednisone.
Yep. Yeah.
Wow. So yeah, I think that that other condition is called GCA, or giant cell arteritis.
Right.
And it's like these arteries on the side of your head and crazy stuff can cause your eyes to go blind. It's like hard to describe. I don't really fully get it, and I'm in healthcare. And so it's just weird how this blindness could have anything to do with muscle pain, right? Like, how do these symptoms and syndromes overlap? Nobody really knows, which is what's hard. And it sounds like your situation is so typical that they had a hard time figuring out what it was, because
unfortunately, many doctors don't know what it is either. I belong to a support group on Facebook, and that is where most of the information is being shared back and forth. And you'd be amazed at how many of the people that have it have been diagnosed themselves and went to the doctor and said, could this be it? And sure enough, the doctors they had no idea.
Yeah, no idea. Because I mean, they teach us most of the conditions in pharmacy school, and this is not one they mentioned. I talked to my little brother who's a pharmacist last night. I was like, have you heard of PMR? He's like, PM what? Never heard of it. But it's not that uncommon too, so it's really surprising that I thought I had like this world of things that I thought I understood, that PMR is outside of that. And so if it's outside of what I understood, and I had a very generalized education, I went even deeper and got board certification in chronic things like rheumatology conditions. Yeah. And I still never heard of it. So I think that's one of the trickiest parts about this condition, is getting that true diagnosis. And so you're saying you went from original problem to diagnosis after just 2 doctors, right? Or is it longer than that?
No, it was 2 doctors, but my general practitioner, she tried everything she could think of. She agreed with me at first that it was probably just soreness from playing with my grandkids in the pool and those motions I went through. But when it didn't go away and I went back, I just kept, it was just, she tried to send me to physical therapy. And when I called and told them my symptoms, they're like, well, do you want to work on your arms? You want to work on your leg? I said, I have to work on all of it. Nothing, I can't move.
Nothing's working.
That wasn't going to work for me, and I wasn't able to physically move. I've only just now started being able to get my muscles working again and be able to get that muscle tone back. It was described to me finally by this rheumatologist who, she knew it, what it was, luckily, and it's some kind of inflammation, like chronic inflammation in between the lining of the muscles and the joints, something like that.
Yeah.
So many people have described it so many other ways, but that's what it feels like. You lose, well, you know, all the symptoms you get from prednisone.
Yeah.
That's even worse. Once you get it and you get out of the pain, then the prednisone becomes the whole other situation. So
Yes. So you mentioned like 6 months to 5 years that it's typical. And for you, it's been just 2 years, right? And so we know that it lasts a certain amount of time. But what about typical doses for prednisone that you've seen? So you said you started at 20. Tell us more about like what was the highest dose you ever went on, the lowest dose you ever went on, that type of thing.
well, when the first time it was obvious, it was a shot and it was a lot. I don't even know. And it relieved the pain, but it came right back with a vengeance. And I think I was on 30 milligrams and then down to 20, that had to go back up. It's a process through the whole time of going up and down. Eventually, as a patient, you start to be able to control yourself, how to what's the word I'm trying to think of? Taper down. Because she would say, well, drop 5 milligrams. Well, 5 milligrams would kill me.
Yeah.
I didn't having to like cut it in half and do 2.5 milligram or, you know, 1 milligram. When I got to the end, I was down to taking 1 milligram and then 0.5 milligram and 1 milligram, like for 3 weeks. It's a long drawn out process,
Yeah.
but I finally got there.
So when would you say you were on 30 and you're on 20? When would you say you were finally able to really start going down?
Maybe, you know what? The first year I was up and down the whole time. In the pain, I couldn't tell if it was the prednisone withdrawal or if it was the PMR. You get to a place in this process, you don't know which is which. The pain is so bad. And then you get depressed and you have all these other feelings that are coming from the withdrawal and the prednisone. But I'd say this last year, I've really been able to concentrate on the taper, but not without pain. I think you start to normalize that and expect it. And you know that you have to go, it's almost like withdrawals on any kind of drug. You have to go through that horrible period to get to that next step. So to go from 10 milligram down to 9 was a painful process. And it took me all year to get to this, to where I just stopped taking prednisone.
Yeah. So what dose change would you say was the most tricky for you? Because I've heard 10 milligrams from a lot of people.
I was just going to say, when you get to 10, getting off, you get all excited and you're like, yay, I'm down. It's a low dose, whatever. You feel like it's a low dose. But getting from 10 to 1 is pure pain. I mean, it is hard. It is hard because I would, when I got to 5, I started just dropping in 0.5 milligrams and I would stay on, I would do 5 for 3 weeks. And then the 4th week, I would do 1 day 5, 4.5, 5, 4.5, 5 for that week. Then on Sunday, I would drop to 4.5. I would stay on 4.5 for another 3 weeks. And then I would drop 4.5, 4, 4.5, 4 until that Sunday, and then drop to 4. And there were several times I went back up from 4.5 back up to 5 or whatever, because, and it took a year. Took a year
of just the tiniest little changes, just
you wouldn't,
that
and that
sensitivity.
that teeny weeny little pill, what it can do, you just are, it's hard to imagine.
I'm so glad to hear you describing that taper in such detail, because I get asked all the time, well, what works? And it's like, you really have to like work with your doctor closely. And when you get to the point where you were, really listen to your body as well to figure out precisely what you can do and how prolonged that was, how truly drawn out that was for you. Just like 0.5 milligram basically every month that's insane. Like how the mental game of it all must have been so hard for you.
Sometimes you had to go back up and it was just so depressing. I mean, it's hard to do because you desperately want off of it. It does horrible things to your body. I showed you a before and after picture of me. when I was like a couple months in on prednisone and I looked like a giant pumpkin.
You look like a different person, like a completely different person.
It was a long process, but it is, yeah, I wouldn't wish it on anybody. I wouldn't. And I mean, you know, there's things you can try, and I tried all kinds of other things too, you know, diet and exercise. You can't exercise. Honestly, you just can't. If
No,
you,
you can't even put your shirt on.
you can't. Or, I mean, you know, I was blessed that I could work from home. That was the only blessing, because that week of the switching, I would go into, you also, it affects your hormones and everything. You get depressed, you are in pain, you are lethargic. There's all these things that happen. And if I couldn't work from home and people had to see me like that, I probably wouldn't still be working.
Yeah, you would have had to leave the workforce, right? Like, this is the taper process itself is so debilitating, right? That it would require you to no longer hold down a job.
I thought, and I had just started a new job when this happened to me.
Oh my gosh.
Yeah, just started one. And I was crying to my doctor. I'm like, please, you've got to give me something I need to keep. I want this job. I like it. I want to keep it, you know.
Yeah.
And the pandemic, as awful as it was, it actually was a blessing to me to have to stay home and work.
Yeah, and it normalized working from home, right? Like, you weren't the only person doing it.
Right.
And that you could do this taper misery and nobody was there to have to deal with it because you were social distancing.
That's right. My little dog was giving me lots of little licks though, because I would be crying or whatever I'd be going through. But yeah, it was painful.
I'm glad you had a dog.
Me too.
That is awesome. So, I mean, when you were describing tapering, you're like, I'm going to drop by 5 milligrams. If you'd gone from 5 milligrams, like if you'd gone from 30 down to 25, would you be able to handle it? Or was it 10 down to 5? But that's like,
it depended. It sometimes, I mean, when I first started out, dropping a lot was not as hard as when you get down to where you're like at 10 and you're trying to get off of it. It seems like it just seems to be just those little half milligrams are more important. When you're way up at the top, it was easier to drop like 5. But then like once you get to 20, it was more like maybe 2.5. Not 5. You couldn't just drop from 20 down to 15 or you were going right back up to, you know,
starting it all over. Yeah. I'm so glad you just described all of that, because it proves to me that it's really a percent that really is what you can do. That you could do 20% or 10% or maybe 5%, but it was always like 20% of 30 was nearly 5, right? Whereas 20% of 5 is 1. And you were really doing like 10%, which was 0.5. And so it wasn't necessarily the milligrams itself.
No.
It was the percentage drop that really made the difference, right?
Yeah, exactly.
Yeah.
And mentally strong you can be to do it. Honestly. I mean, my mother would listen. She could tell by my voice. Oh, you're dropping, aren't you? She literally on the phone know that I was in that week that I had tried to drop, because she could hear in my voice the pain, you know, that I would go through, or the depression or whatever. Yeah.
And so how are your moods now?
I'm off of it.
Yeah.
But I know that it lasts and stays in your system probably 6 months to a year. That's what my doctor told me to be prepared for. She said, don't expect to just drop all your weight. Don't expect to just go back to being, you know, like you were. And the other thing that happens, not to someone in your age group, but in mine, is you can't tell if you're aging, if it's PMR, or if it's the prednisone, because in this process, you're continuing to get older. And so when you start, your hands start to hurt or other things, you're like, is this PMR? Is this prednisone withdrawal? Or is this arthritis? What is it? And nobody can help you diagnose any of that.
Yes, I think that is the trickiest thing, because I mean, I was having hot flashes in my 30s. Like, what? You know, like, this isn't normal. And like, it does the strangest things to you. But having that I hadn't had anybody quite describe it the way you said. Where is it aging, or is it prednisone withdrawal, or is it your actual condition coming back?
Yeah.
That is such a tricky distinction to figure out. Did you ever be like, oh, I think it's really this? Like, what would lead you to one or the other?
Well, it was, I talked to other people. I was in this support group on Facebook that honestly, anybody that has PMR should get on there.
Yeah.
Because more information there. And I recommend you all the time on there, because I'm like, you're on prednisone, you need to listen to this doctor. She knows, she's been on it as well as she's trained, so excuse me. I lost my train of thought, but most of the advice that I found that was most helpful to me was support groups and talking to other people. I talked to my gynecologist, I talked to nurses, I talked to friends, and it was amazing to me how many people actually had PMR that also that had never heard of it before, but had just gotten it as well. When you become part of this social group, all of a sudden,
It's everywhere,
buy
right?
a yellow car and you start to see yellow cars. You know what I mean?
Exactly. Yes. I feel the exact same way. Yeah, my original question, and I love that Facebook support group is amazing. And the question was, did you ever figure out, was it joint pain from aging, joint pain from PMR, or joint pain from withdrawal from prednisone? Did you ever figure out a way to distinguish it?
I could kind of tell. I knew that the pain in my shoulders and the pain in my hips was PMR.
Yes.
But when you're tapering off the prednisone, which is supposed to help with the pain, and it comes back, then your assumption is, okay, well, I need to go back up on the prednisone. But if your hands start to hurt, or your knees, which other people have said they've had those symptoms as well, I'm like, well, have I got my knees joints wearing down? Am I getting osteoarthritis? You couldn't really tell. I always knew the depression and the mood swings were prednisone. Always.
Oh yeah. Oh yeah. For sure. Those mood changes from prednisone, like you can nail it on that one for sure. 100%. They're directly.
And I'm no longer in that age group where I have a monthly cycle. So I knew it was prednisone.
It couldn't be the hormonal cycle causing the mood change.
It was not PMS. It
had
was
to be the drug.
prednisone.
Yes, definitely. Oh, I just love how you're describing all of these things, because I think having somebody to describe it helps other people to be like, oh, it's not just me. I'm not the only one who couldn't figure out where this pain is coming from, why I'm having these mood swings. It's so empowering knowing that it's not you, it's the drug, right? And keep going.
I feel sorry for a lot of people, because family members, you look normal. You look like you're fine until you try to get out of a chair or try to put on a seatbelt or something like that, and you cry or you groan, and they're like, oh, what's wrong with you? Getting the sympathy and the understanding from your family is also difficult. I live, I don't have that situation in my personal life, but I've read so many people who have actually struggled with that understanding that there's something wrong. And just because you look normal, with your makeup on and your clothes or whatever, you feel like hell. Yeah. And it's horrible,
Yeah. So what would you say if you were trying to describe this, like what you wish your family knew, to your mom or your sister or your children, whatever? What would you say? Like, how would you be like, this is what I wish you understood about PMR or prednisone?
Well, lending credibility to it, seeing other people talking about it, knowing that it's a real thing. And that, for my mom, she started to understand, because strangely enough, someone in her that she worked with also had it and had gotten over it. And one of my girlfriends, her brother got it in the course of my having it. And I was able to kind of help him through some of it. And I've found, talking to people, I had a girlfriend that I didn't know had lupus and had been on prednisone and is on it to stay alive.
Yeah.
I'm sorry, I got back from a vacation and I have got something. I went in the mountains and now I'm in the heat and it's like messing with me. But I think I would want people to just to research it, to to maybe look at the support group. That's where I found the most information. YouTubing things, trying to figure out, YouTubing prednisone use, having your family actually see that there are other people out there that are suffering, and it lends credibility, that. So, just being patient and really believing people. I don't know.
Yeah, that this mood change isn't me just being mean. It's the drug, right?
I think that was the number one thing, because my ex-husband was remodeling my bathroom for me. We happened to be happily divorced in a very good relationship. And he was remodeling my bathroom. And I would come home from work sometimes after a day of being in pain and trying to pretend I wasn't, which is what you do with this when you're out around other people. And he would just do something like simple about changing a paint color on a certain area, and I'd just fly off the handle and be crazy. And he's like, what is going on with you? I've never known you to act like that. He moved away, he moved to Florida. I said, I'm done. But all seriousness,
It's true. Like
is,
he's known
really,
you for years, right? For
you
long.
can't control it. You can't control it. It is something that is just hormonal. I would see myself and think, what is wrong with you? Why are you so emotional? And I could sit down and just cry for no reason. Just cry.
Yeah.
I'm not a crier. I'm not one. I just am not. I've never been, but I have the last 2 years.
Yeah. I mean, out of sheer pain or out of just the emotional strangeness of prednisone.
Or you could just cry for the fact that you're just crying. Prednisone just makes you crazy.
Mm-hmm. It really does. It really does. I felt the exact same way, and I have no other mental health issues, but while on prednisone, I do.
I get it.
Yeah.
Until I started taking it.
Yes, exactly. Okay, so let's see. So we talked about what to have our family expect. What would you tell others who are taking prednisone to expect?
A roller coaster ride, but I wouldn't want to discourage them for not taking it, because it does fix the pain. It has credible, faculties that when you are in that much pain, it is helpful. I won't lie about it. If I had to go back to feeling like I did versus taking the prednisone, I would take the prednisone. The hard part is getting off the prednisone. Once you get that pain under control and then you start trying to taper, I would suggest trying to taper as fast as you can before you get too much into your system and it becomes hard to get off of it. If I had to do it again, I don't know if I wouldn't look for alternative ways to combat that. But, when you're in that much pain, all you want is something to make it better, so.
Yeah.
I mean, I started doing acupuncture and it helped. It really helped a lot. I'm now able to do physical therapy, which I'm trying to regain some of my muscle tone back, and some of my movement, my
Range of motion?
yeah, my flexibility, because I couldn't. I mean, this was impossible probably a month ago.
Wow. You've made that much progress.
A month ago. I couldn't have done that. I can tell you, because I was at physical therapy and she's like, we got to start working on that. And yeah, it's a process.
It's a process. Yeah, they say like one of the diagnoses is, can you make the touchdown? And it's, nope, can't make the touchdown sign.
Putting on my socks was like a goal. Just being able to put on a pair of socks, to put the seatbelt on and not be in so, it was the worst thing. To try and put a
Just
seat.
reach that and go across and just use your shoulder like that.
It's this right here is the air. I can still have pain here. I can still feel it even right now, but it's not like so debilitating. It's a horrible, horrible thing. I hope that people that have it are able to see this and know that they're not alone, because so many people have it and it's a horrible thing, but it does go away. I'm living proof.
Yeah, it does go away. There is hope.
Yeah.
The tapering process isn't fun, but it can end. Okay?
It does end. Yeah.
It does end. So what was your favorite snack when you got the munchies while on prednisone?
Oh God, crunchy Cheetos. I hate them. And they hate me back so bad, but orange fingers, all of it, but I tried so hard, because really all that does, and I'll be honest with you, when you eat that stuff, when you eat sugar and useless carbohydrates, you will have more pain. It really does make a difference when you try to cut out some of the carbohydrates and try to eat the sugar, and you try to eat a balanced, healthy diet, which, we all say it and everybody says it, diet and exercise, but it's true. You can't exercise, honestly. Just moving your body is about all you can do, to survive. But if you can try to watch some of that, I could tell a difference from a night when I would have a bowl of Cheetos in front of the TV because I was feeling sorry for myself and it made me feel better for the moment, versus the next night when I hadn't done that and I'd ate well that day, that next morning I wouldn't be in as much pain, because PMR hurts the most in the morning. And when you're in bed at night, try to turn your body over in bed is brutal. It'll wake you up. It hurts that much.
Wow. Yeah, that bedtime is such a rough situation, because not only is there your pain, but then prednisone is making you wired and hard time falling asleep.
That it didn't do that to me. And
Lucky.
some people really like that because they get to they can clean their house and they do all kinds of stuff when that happens. But I didn't have that experience with it once I got under 10 milligrams. And when I did have the experience, I couldn't move anyway. So it didn't do me a whole lot of good.
Yeah. And so you're just sitting there staring at the ceiling when you're on those high doses, right?
That's why my doctor told me to take half in the morning and half in the evening. And that way I would have the full dose 24 hours and it wouldn't have as much effect on my sleep. But I think the type of job I have I would sleep okay. Usually my pain would be what would wake me up.
Yeah. Wow. What a tough situation. I'm so glad to hear you're recovering. Oh my goodness. This has been so helpful for me to understand your perspective as somebody who's suffered so much, somebody who's been completely through it, the entire process from start to finish, that you can be like, it's worth it, but you are paying the price, right? Yeah. And so if you have any last advice for people who have PMR and have to take prednisone?
I just, just stay the course. Try to keep I meditate every day. That helps me. I would at lunchtime or whatever, with work, I would take, even if it's just 10 minutes, I would take and do a guided meditation on YouTube or something to just kind of get out of my body and into just breathing in my head. And that helped me a lot. Watch your diet and just know that it does end. It does end. But you just have to stay the course and you have to just prepare yourself. It's tough. I mean, I admire anybody who's going through it and anybody who has gone through it, because it's mental strength, I believe, gets you through it.
Yes, it's not just a physical dramatic pain, but it's a mental game to get through that whole process.
Yeah, I mean,
keep hope, right?
It's the prednisone withdrawal that really was the hardest part, not the PMR. I mean, the prednisone gets that pain under control to some extent, but then trying to get off that medicine, because it does awful. You blow up, your skin gets thin, your muscle tone's gone. So many things happen with prednisone, but it comes back. I'm told it does. And I'm starting to see better changes in my body that I'm grateful for, even though I'm old. So.
Yeah, but prednisone makes you feel way older than you really are. And so I'm glad to hear that those changes are coming back. Like, I personally lost hair. It was awful. I'm just so glad it's come back. I've healed.
Yeah.
Right.
Yeah. One other thing that I really helped me, and if I'd have known ahead of time, I might have done, was getting into the water. During the summer, if you can move your body in a pool, don't overdo it. And then maybe in the winter, like I'm going to join a community center where I can go and get in the pool during the winter, because doing any kind of resistance and trying to kill yourself to exercise is the worst thing you can do, because you're going to hurt yourself. But doing nice, easy, gentle stuff is helpful to keep your body moving. So
I love that advice, because the water provides that gentle resistance that just physically being in there, not only does it like require effort to move, but the temperature of the water actually helps you with your metabolism. Like they did studies like with Michael Phelps, he was the best swimmer of all time, and he was metabolizing so many calories, but they couldn't figure out why. Like, why was he going through, like, I don't know, some obscene amount, like 12,000 calories a day? And it wasn't just because he was moving so much, but it was also because his body had to make heat to cope with being in that pool that was lower than his natural body temperature. And so it's this like water aerobic exercise is like one of the best things you can do if you have the ability to get to a pool.
Yeah, but make sure you have the ability to get out of the pool somewhere safe. Honestly, once you try to get up out, your body feels like lead cement. It's so hard. That's how you feel in the morning. Your legs feel like wooden posts, but in the water, it's freedom. But just make sure you don't get in the water where you can't get out somewhere. I have the steps that I can get in and out of on the steps. It's safer.
Wow, I never even would have thought of that, but
I'm up,
that's where that could have been if you had to pull yourself up using the ladder.
Oh my God, it's horrible. Your body feels like cement.
Yeah.
So
and like lifting your arms high enough to grab the ladder, I can't even imagine.
Thinking about it hurts me, and I don't have that pain anymore because I remember it.
Oh my goodness, that is such a good tip. I never would have thought to ask. Like, if you do water aerobics, what should you do for sure? Have a way out.
5 foot of water. Make sure you can get out in the kids section.
Oh my goodness, how interesting. Okay, well, Diane, this has been amazing. I really appreciate you taking the time out of your workday to tell me all about your journey as a prednisone warrior with PMR, polymyalgia rheumatica. Thank you so much. And we'll be signing off. I'm Dr. Megan, your prednisone pharmacist.